have your hand raised. I hope all is well. If not, let us know. You can reach out to Paul so that we can start in the interest of time. So we have a team here in Nairobi, Serena. My name is Dr. David Kamau. I'm inviting you on behalf of BI together with my colleague, Paul Mukundi. This is a follow-up towards what we call an ILD Summit. We have a few members here brought in from rheumatology, pulmonology, and even radiology. And we also have members joining online. So we like to start in the interest of time. Just want to confirm few aspects just to make sure we accommodate everyone. Just bear with us. So, very good. So I won't focus a lot of this because of time, but we do believe that we do have eminent speakers both here in Kenya as well as in Ghana and Nigeria who will tackle this burden and in terms of the disease area and context. Just want to also inform the audience that we'll also have some interactive case studies that will be discussed from various faculties from Kenya, Ghana, and Nigeria. Together with that, we have some radiologists as well joining us online that will also discuss some aspect. But in terms of the meeting objective, we'd like to follow up some of aspect we've already done in the past 2 years. We started off by engaging the Respiratory Society of Kenya in terms of raising awareness about ILD as a disease, followed up by the gaps that we have already done. Paul has done an extensive work looking at the advisory board in Ghana as well as here in Kenya. What are the gaps in ILD as a disease, various phenotype, and we identified MDT, multidisciplinary collaboration, as one of the aspects, as well as improving patient identification, awareness, and referral. So the purpose of today's meeting is to continue on that narrative, expand the scope towards our colleagues in West Africa. At the end of the day of today's meeting, we'd like as much as possible to, build a consensus and probably come up with an areas that we can address in terms of research gaps, in terms of how we can create centers of excellence, but most importantly, to encourage that multidisciplinary and peer-to-peer discussions around ILD as a disease. I would like also to point out that we have also 2 eminent moderators for today's session that I will invite shortly, that will also introduce other panelists. And of course, I'd like to encourage our online viewers to be as interactive as much as possible towards even the last part of the interactive case studies. On a high level, this is what we have achieved in the last 1.5 years. Looking at the disease awareness, looking at small focus group discussion in terms of MDTs, looking at advisory board that have been done already here in Kenya and Ghana. And we had a small similar event here in Kenya, which was an ILD workshop that we like to expand the scope around that discussion around ILD as a disease. We have 2 online speakers joining from Ghana. They couldn't travel because of commitment in terms of West Africa College of Physicians engagement. Dr. Zifa and Dr. Foson joining us online. We also have the rest of the speakers here with us in Nairobi. I'll give a chance to our moderators to introduce them as we go through the agenda, as well as an invited speaker as well from South Africa, whom I'll invite Dr. Kagima to introduce the rest of the session. So because of time, Dr. Kagima is our first moderator for the first track, which is around pulmonary fibrosis. As you all here know her very well, to our online viewers, Dr. Kagima is a respiratory physician based at Kenyatta National Hospital, which is one of the foremost public hospitals here in Kenya. She has done a lot of research and has, of course, worked across various institutions and has a PhD from LSTM UK. And I'd like to speak more about herself in the follow-up kind of discussions. But I'd like to invite Dr. Kagima to come and introduce the whole spectrum of the whole afternoon session, as well as introduce the rest of the speakers and take up the discussion from there. Welcome, Dr. Kagima. Thank you.
Um, good afternoon, everybody. Good afternoon. Why are you all looking dull and we're just starting? So my name is Dr. Wanjiko Kagima. I'd like to welcome all of you for this very engaging session in interstitial lung disease. My slides are more, honestly, it's just about the welcoming committee, if there's something like that. So basically just to tell you how this started and where we are as Kenya in terms of interstitial lung disease. And I'd like to acknowledge my mentor, especially in pulmonology and interstitial lung disease. He's seated right there, Dr. Tina. Please wave to the crowd. He's the brain behind starting an interstitial lung disease forum, honestly. I just took it up, but he was the brain behind it. I'd also like to appreciate the presence of our patron. He's the father of respiratory medicine in Kenya, Prof. J. Aloch. I will not ask him to wave, he's a mzee. But we know him, karibu sana, Prof. Oh, Prof. So, Prof, he's right here at the front. He's at this front table. Yes, the gentleman with a very good suit. Yeah. I would also love to invite, to just welcome our counterparts, all the pulmonologists in Kenya, Nigeria, Ghana. Please feel very welcome. Karibuni. We usually say karibu. And South Africa, please. Karibu sana. Karibu sana means welcome. So how did we start? These are my disclaimers. I have no financial interest in, sorry. Thank you. So the purpose of this meeting is to facilitate expert discussion across sub-Saharan Africa, where we have Kenya, Nigeria, Ghana, and even South Africa. South Africa is sort of our big brother because you're probably more advanced in terms of interstitial lung disease diagnosis. So you're a big brother. The rest of us, and I'm speaking largely for Kenya, this is just a new thing, so we are still trying to get a grip of how to best diagnose and manage interstitial lung disease. And how we are going to do this, we're going to have case studies, we're going to have presentations from some of the pulmonologists within the region, and we're going to share insights when we share the case studies. So in terms of the how, basically, we're going to do it as a multidisciplinary teams approach, and we're going to have multidisciplinary team discussions. And this team is made up of pulmonologists. We hope rheumatologists will come. We had invited some, even online. We have radiologists. Our thoracic radiologists are already here. We will appreciate them. Dr. Ombati, who is our first trained thoracic radiologist in the country, is seated right here. We have Dr. Onyinkwa, who is also head one of our private hospital radiology department, and others are joining online and they will also come. We also have pathologists in the team, and this list is not exhaustive. We also have nurses in the team, and we have other clinicians that we consult once in a while, including even cardiothoracic surgeons who help us when we cannot get biopsies. Why? Because the why come together as a team? We know currently that MDDs is the standard approach. Actually, it's the best approach in terms of evaluating ILDs due to its high level of diagnostic confidence and high inter-observer agreement. That is why we decided to form this team. And I do not want to belabor the issue of multidisciplinary team discussion. Basically, you know that we integrate a lot of information, clinical, radiological, pathological data, then we make a specific therapy as a team together. So in summary, what I just want to say, ILD, it takes a village. It takes a village to manage this patient. It takes a village to diagnose these patients. And it also takes a village to institute therapy for them. With that, I would like to just go through the plan of today. So to start us off, we'll have 4 sessions for today. So session 1, we're going to focus on the idiopathic pulmonary fibrosis topics, and we'll have various speakers who I will introduce later. Then we have session 2, which focuses on connective tissue disease associated interstitial lung disease. We have 3 speakers during that, and also some Q&A. We have the third session, which is on progressive pulmonary fibrosis, with a few speakers in that session. And then the last session, we're going to have challenging cases. We plan for 3 or 4 challenging cases where we're going to now do the MDD and discuss the management of those cases and forge a way forward. Allow me to... Okay. I can introduce them. Allow me to introduce the first speaker. Okay. They don't have a mic. Dr. Foster. So our first speaker is online. I hope she is ready. So I have the pleasure of introducing Dr. Audrey Foson, who is a pulmonologist and a graduate of the University of Ghana Medical School and a fellow of the West African College of Physicians and founding fellow of Ghana College of Physicians and Surgeons. She obtained a Master's of Science degree in respiratory medicine from Imperial College of Science, Technology and Medicine, University of London, UK, and had training as a pulmonologist at the Brompton Hospital, London. Dr. Forson is a member of several international thoracic societies, including the Pan-African Thoracic Society, the European Respiratory Society, and the American Thoracic Society, and a founding member and first president of the Ghana Thoracic Society in 2014 to 2018. Dr. Forson, I'll say in Swahili, karibu, welcome.
Yeah, thank you very much. I'm ready to start. If you stop share, I could start. Could I please mention that my other colleague from Ghana is not on the panel. She's not been enabled to join the panel. If you can sort that out, please. Dr. Jaffa.
So we are working to upgrade her. Just a few seconds. So Dr. Foson, please go ahead.
Yeah, okay. Thank you very much. And good morning again. Good morning to colleagues. My topic is an overview of interstitial lung disease. And I will say that by the end of this seminar, by the time we finish with all the topics, then we'll have a comprehensive overview of interstitial lung disease. So next, please. Yeah, I have no disclosures. I am contracted by BI to present this seminar. So the outline, what is ILD? We classify it. I talk a bit about IPF and other ILDs, the diagnosis, the procedures we go through for diagnosis, progressive pulmonary fibrosis, and treatment. And all this will be in 20 minutes. So it's just to touch on these things. I know we're going to be delving into it much more extensively, so it will not be long. Thank you. Next one. So what is ILD? Interstitial lung disease is also known as diffuse parenchymal lung disease, also referred to as diffuse parenchymal lung disease. And it refers to a large heterogeneous collection of lung disorders that are grouped together because they share clinical, radiographic, and pathologic features. And I want us to be clear what we mean when we talk about interstitial lung disease. The parenchyma of the lung is the functional part of the lung, comprising the components that are involved in gas exchange and includes respiratory bronchioles, pulmonary alveoli, and the extracellular matrix and cells. It excludes the lung circulatory system, while the interstitium is a network of connective tissue that supports the structure of the organ. So I want to make it clear that as most pulmonologists, we do not distinguish between diseases that affect the lungs interstitium or its parenchyma. So interstitial lung disease is a broad term. It goes beyond the interstitium. That's the point of this slide. Next one, please. And so this is just to show you a classification of the idiopathic interstitial pneumonias. This is from a 2013 classification, which gives us 6 groups of 6 interstitial idiopathic interstitial pneumonias within the major group. And they are idiopathic pulmonary fibrosis, non-specific interstitial pneumonia, respiratory bronchiolitis, interstitial lung disease, desquamative interstitial pneumonia, cryptogenic organizing pneumonia, and acute interstitial pneumonia. And add to that the rarer ones, the lymphoid interstitial pneumonia and the pleural parenchymal fibroelastosis. And I just want to mention that these classifications have been changing. And the earlier classification would have had the 7, including the lymphoid interstitial pneumonia. So the pleural parenchymal fibroelastosis was relatively new. Unclassified idiopathic interstitial pneumonias where the workup hadn't been complete and they were not enabled to place them in a particular category. Next slide, please. So then we come to the classification of interstitial lung disease currents. So that is the 2018 guideline, which was produced by the ATS, ERS, the Japanese Thoracic Society, as well as the Latin American Thoracic Society. And so we have them broadly grouped as etiology known, etiology unknown, which is the same as idiopathic. So the etiology known includes well-known conditions like inorganic exposure would be the pneumoconiosis, the asbestosis recognized, and a lot of these are occupational related conditions. Coal dust exposure, hard metals like beryllium, so berylliosis. And then you have the organic exposures, which tend to cause a hypersensitivity pneumonitis. And the classical ones would be the pigeon fanciers disease or bird fanciers. And this is allergy, inflammatory response to protein. So the fecal protein or bird feathers. You have moles, you have hemophilic bacteria, and even mycobacteria has been known to cause a condition called hot tub syndrome. That's the Mycobacteria avium intracellulare. So that's also well known as hypersensitivity pneumonitis. And then I'll talk about the drugs. A few well-known ones, but there are more. Nitrofurantoin, which is used for treatment of UTI, amiodarone, used for cardiac disease. Methotrexate is a chemotherapeutic agent, and other chemotherapy has been recognized as known to cause interstitial inflammation and fibrosis. And then I'll talk about the connective tissue disease, which I think will be about the most well-known cause. I wouldn't say the commons, but the most well-known cause of interstitial lung disease. And there are various manifestations of it. So rheumatoid arthritis is well-known, polymyositis, dermatomyositis, scleroderma, and Sjogren's syndrome. There are others, but these would be key ones. Then there's a group which have been related to smoking. So clearly, smoking is an etiological factor in DIP, stands for desquamative interstitial pneumonia. And then respiratory bronchiolitis, interstitial lung disease. These two were initially in the 2013 guideline classification, were initially added to the idiopathic interstitial pneumonias, but in the 2018, it's been put into a group which is smoking etiology. And then you have Langerhans cell histiocytosis, which has been well known. Not common, but well known. Then we come to the idiopathic group, and the idiopathic group is grouped into the idiopathic interstitial pneumonias and the others. And the idiopathic interstitial pneumonias this time are fewer in number than the 2013 classification, as I've said already. And in these, you want to know whether it's IPF, idiopathic pulmonary fibrosis, or other. And the non-idiopathic pulmonary fibrosis groupings, idiopathic interstitial pneumonia groupings, are the non-specific interstitial pneumonia, the cryptogenic organizing pneumonia, lymphocytic interstitial pneumonia, and acute interstitial pneumonia. So these would be the key ones under the IIPs. And then they have mentioned sarcoidosis, we are quite familiar with. It is in this group because the etiology is still unknown, even though it's very well characterized, and it has very clear-cut radiological presentation. It's still under etiology unknown. And then we have rare forms of ILD, lymphangioliomyomatosis is a rare cystic form of interstitial lung disease, occurs in women of childbearing age, and the vasculitides other than connective tissue diseases can present with interstitial lung disease. And then fibroelastosis refers to the newer one that I mentioned in the slide before. So that is the fibroparenchymal fibroelastosis, also considered a form of ILD. Next slide, please. So just to talk a little bit about IPF, we'll talk a lot more about it in the subsequent presentation. So this is to mention, it's idiopathic pulmonary fibrosis is defined as a specific form of chronic progressive fibrosing interstitial pneumonia of unknown cause, occurring primarily in older adults, and is limited to the lungs. That's another key point. And it is associated with histopathologic and or radiologic patterns of UIP. The UIP stands for usual interstitial pneumonia, which is a very classical description of both the radiology as well as the pathologic findings. It is characterized by progressive worsening of dyspnea and lung function, and it has a poor prognosis. It's more common in men, with a ratio of about 2:1, and it's also more in the older age, 60s and 70s, I've mentioned already. Also, there's an association with cigarette smoking, which is now being more clearly recognized. Next slide, please. So we have the prevalence is variable because the definition wasn't clearly defined earlier on. So we've had several studies, but currently there's a more recent study in the US that suggests that about 14 to 42%. 14 to 42 persons per 100,000 may have the disease, which sounds a bit high. Prevalence in Africa, I don't think it's been determined, so I suspect it is low, but we don't know. So I mentioned that the significance is poor prognosis and the difficulty in treating this progressive fibrosis. The other associations of IPF would include gastroesophageal reflux disease, and chronic viral conditions like diseases like Epstein-Barr virus infection that you see. And then there's also recognized that it's familial. And of course, I've mentioned the relationship to smoking. There are other associations of comorbid conditions, and one of them, combined pulmonary fibrosis and emphysema, is recognized in patients who are known to have emphysema, but later have this rapid progression. Also in other conditions like lung cancer. Pulmonary hypertension would be a complication. I'll just move on. And OSA. Next slide, please. And so the other ILDs, just quickly mention a few. So the other ILDs, I'm not going to really describe the HRCT findings or the biopsy findings, I just put them there, but I'm not talking about them. but hypersensitivity pneumonia is the one that is most frequently confused with the non-specific interstitial pneumonias and the IPF. And it's one of the first things that in your clinical history taking and diagnosis would want to exclude. Usually you give a questionnaire to the patients and ask them any of their exposures. They should just highlight any of the exposures they may have had. And sometimes as you progress with the follow-up, some of these exposures become recognized and might convert what you thought was an idiopathic interstitial pneumonia to an HP. So the collagen vascular diseases tend to cause non-specific interstitial pneumonia, and they are considered idiopathic interstitial pneumonia. In some cases, that may be the first presentation of the collagen vascular disease and may not have all the serologic criteria for specific diagnosis, but they're still considered an idiopathic interstitial pneumonia. The smoking-related ILDs were mentioned in that earlier slide, and so I will not belabor the point, but just to state that the respiratory bronchiolitis ILD is actually what is seen in current smokers, but there's a variation in the degree, and so a more advanced form of the disease would present itself as respiratory bronchiolitis interstitial lung disease, and it's now considered that smoking is the cause. Let's move on. Next slide, please. Then there are the cystic interstitial lung diseases, which are cysts are air-filled lucencies of low attenuation. I'm sure this will be explained further by the radiologist who is presenting. And I'll just mention Langerhans cell histiocytosis, which is well characterized. It gives amorphous-looking cysts and nodules. Nodular, some of the nodules may cavitate. Then we have the lymphangioliomyomatosis, which is LAM, I've mentioned already. It can be sporadic, or it can be a manifestation of tuberous sclerosis. And it's also very rare. And they've also identified that there may be some abnormal genes possibly relating to it. So it may be an inherited, complex inheritance behind it. Then you have the lymphocytic interstitial pneumonia, which is very rare. Typically can be idiopathic, but it has been recognized in association with some collagen vascular diseases, and HIV infection has been known to give you LIP. And then even malignancy, which may be metastatic, or primary, but tends to be lymphangitic in character. So lymphangitic carcinomatosis can cause the inflammatory changes and fibrosis. And then we know that some chemotherapeutic drugs can cause it, as well as radiation therapy for lung cancer, for breast cancer. Next, please. Can I have the next slide? Yeah. So these are some other causes. I've mentioned that the occupational related causes can be either organic or inorganic, and these are some examples. And then the drugs, there are a lot more listed, but the key ones we've mentioned. Next slide, please. Next slide. So in diagnosing interstitial lung disease, in clinical practice, patients are commonly misclassified. The best of us have been caught out in that way. And we classify them as having an IIP, and then later with additional history taking or additional presentation, clinical examination, we find we have a more obvious diagnosis. So in addition to that, an increasing number of associations between the development of diffuse parenchymal lung disease have been noticed in occupational, environmental, and drug exposures. And this is a developing thing. Therefore, during the diagnostic workup of the IIPs, a diagnosis may need to be revised at several stages as more details of history are obtained, or when new associations are discovered, or as you investigate further when results of bronchoalveolar lavage, transbronchial biopsy, or surgical lung biopsy become available. Next, please. Next slide, please. So the diagnosis of ILD, we start with clinical. Clinical is major, yes. Comprehensive clinical history taking as well as examination is important, including looking for skin changes and the like. And you also would want to include chest x-rays and pulmonary function tests. And within chest x-ray findings, in some cases may be quite typical and might give you a clear-cut diagnosis like sarcoidosis showing bilateral hilar adenopathy. And in that case, HRCT may not be necessary. So it's not always invariable. And then you should, by that, also be able to exclude infections like bronchiectasis or malignancy. That should be ruled out, whether primary or secondary metastasis. Lung function tests, the key thing is the diffusing capacity for carbon monoxide is the most sensitive test. You will see reduction of your forced vital capacity and total lung capacity, but it's not it doesn't change as fast as the DLCO would for follow-up of patients or for recognizing deterioration. The high-resolution CT tomography is well recognized as a diagnostic tool and may be able to make the diagnosis in certain conditions, such as IPF, where you see the usual interstitial pneumonia pattern, even in sarcoidosis, where it tends to have nodular changes along the septal planes. So in that case, you would not need to go further to obtain a lung biopsy. Bronchoalveolar lavage, there are certain indications where the HRCT scan and the history is not able to make the diagnosis. And then serological tests. Serological tests, particularly looking out for connective tissue disease, would be done. But bear in mind that some patients with IPF might have mildly positive antinuclear antibody titers or rheumatoid factor high. And so it's a combination of your history as well as your labs. And so you do these other antibody tests such as the anti-Jo1, anti-SEL70, SSA, SSB, and some of the others. There also can be serology for suspected hypersensitivity pneumonitis, where you do your specific IgG precipitants for particular environmental exposures where it's available. And that might help with correlation with the history and examination findings. There is a strong recommendation in the most recent guidelines not to really look out for serum biomarkers for IPF. There are some which have been mostly linked with research, and it's not a routine investigation. Okay, next slide, please. Next slide, please. Yeah, so I did mention UIP, but this is going to be discussed by the radiologist. But there's the fact that, for example, the classical presentation on HRCT for IPF would be a subpleural distribution of the abnormality and honeycombing, typical fibrotic changes from honeycombing and traction bronchiectasis. So that's all I'll say about that. The next slide, please. And when we talk about the HRCT abnormality, we hear us talk about inflammation and fibrosis and all that it involves. And so ground glass appearance or ground glass opacification is often described, which is a grayish appearance of the lung parenchyma, but through which you can see the lung markings and vascular markings, as well as you see septal thickening, which may be smooth or maybe nodular. Nodular septal smoothing I mentioned can happen in sarcoidosis. Then you also notice peculiar honeycombing, where you have regular subpleural cysts formation, and is described as honeycombing. Next slide, please. And the distribution of the disease and the types of patterns, whether it's nodular or it's reticular or combined reticular-nodular, all have an important part to play in determining. But this is where the discussions with multidisciplinary discussions come in with your radiologist and with the pathologist. Next slide, please. Can I have the next slide? So this is clear. Okay. So the diagnosis of interstitial lung disease, I've mentioned the major 4 parts. So just to explain the position of bronchoalveolar lavage, that if you have a diagnostic HRCT, which is the central arrow, you don't require any further investigations, no biopsy. But where it is non-diagnostic, bronchoalveolar lavage may be helpful in looking at the cellular patterns to determine the likelihood of a known cause, like hypersensitivity pneumonitis or sarcoidosis, or suggestive of possible diagnosis. If not, then one would go on to do a surgical lung biopsy, and surgical lung biopsy could actually be bronchoscopic cryobiopsy, where in centers where there is that skill and it's been a well-established investigative tool, it can be done, or better than do thoracoscopic surgery and then do the biopsy there. Where there is extensive honeycombing on the extreme left of this flowchart, you find that it's not worth it going further to do bronchoalveolar lavage or lung biopsy. It's just supportive care, because established fibrosis actually would not differentiate the etiology. Thank you. Let's go to the next slide, please. Next slide, please. So there's some benefit of using bronchoalveolar lavage where there's an acute onset of interstitial lung disease, sometimes acute on a background of chronic disease, which may change the HRCT picture such that it's not clear now what you are dealing with. And so then bronchoalveolar lavage, which normally would give you predominantly macrophages, usually over about 85% of your cellular pattern would be macrophages. In this situation, you tend to have abnormal patterns. And so where you have a predominance of eosinophilia, eosinophils greater than 25%, anything more than 1% is abnormal eosinophils. You think of eosinophilias. If you have predominance lymphocyte or high levels of lymphocytes, you consider a drug reaction or acute hypersensitivity pneumonitis. And usually, if you have lymphocytes, they should be less than 3%. Then, if it's blood stains or other findings, it may be of guidance. If it is not, that's when you proceed to a lung biopsy. Next slide, please. So, we have already been told about the value of multidisciplinary discussion, and it's actually essential for diagnostic accuracy. And it has been built into the algorithm. So in the most recent guidelines, it's built into the algorithm for diagnosis. After the initial workup up to your HRCT, there's discussion with the radiologist, between pulmonologists and radiologists, and pathologists to decide if there's a need for further bronchoalveolar lavage or surgical biopsy. And then after these tests have been done, again, there should be a discussion. And timely referral to ILD experts is encouraged where there's difficulty in determining the next step. Next slide, please. So I just want to mention, and this is going to be a topic of a whole section, that there's been increasing recognition of the tendency of non-IPF interstitial lung disease to progress with progressive fibrosis and deterioration in patients' lung function and clinical condition. And this, the most recent guidelines on that came out in 2022, and it has been quite significant because these patients generally have a poor prognosis similar to IPF. So in the most recent guideline, which is the ATS, ERS, JRS, ALT guideline 2022, it has been defined, progressive pulmonary fibrosis has been defined as at least 2 of 3 criteria: worsening symptoms, radiological progression, and physiologic progression. And physiological progression would probably be a deterioration in your DLCO, which as well as the lung volumes, reduction in lung volumes, occurring within the past year with no alternative explanation in a patient with an ILD other than IPF. So that's the definition. Next slide, please. And this, next slide, please. So there are some X-ray changes or HRCT changes that one would see, as well as X-ray changes that might be obvious. Similar pictures, similar findings that you will find in like honeycombing, like UIP, a few features of UIP, but the disease is diffuse. It doesn't fit the description of IPF. And you will find that in this example, they have basal honeycombing subpleural at the lower lung zones bilaterally. But the second picture is that of an expiratory blood flow, X-ray picture, CT scan, which then highlights the fact that this is more of an hypersensitivity pneumonitis, showing you the mosaic pattern, which is more obvious in the expiratory picture. Next slide, please. So this is an example of primary progressive fibrosis. So coming to this, the treatment, I'm near the end of my presentation now. So coming to the treatment, one where there's clear-cut exposure-related ILD, removal of exposure is important. And smoking cessation, of course, is important as well. And then there are immunosuppressive therapies for some of the ILDs that respond to them, and the idiopathic interstitial pneumonias like NSIP that respond to these therapies. So corticosteroids are one. We use quite often azathioprine, mycophenolate, mofetil, cyclophosphamide, rituximab. Rituximab is one of the biologics, anti-CD20, that has been found to be effective in some conditions. So drugs can be used, but typically idiopathic pulmonary fibrosis doesn't respond to steroids and doesn't respond even to these immune modulatory drugs. And so the antifibrotic therapy has been the mainstay of this treatment, and pirfenidone was one of the earlier ones approved for IPF, and nintedanib now is approved for IPF, scleroderma associated ILD, progressive pulmonary fibrosis disease. And then lung transplantation for where there's extensive fibrosis. You can't even look at or determine the original etiology. Lung transplantation must be considered quite early. Then we give supportive therapies like pulmonary rehabilitation, oxygen, home oxygen, long-term oxygen therapy, sometimes with requiring non-invasive ventilation alongside it. We treat acid reflux, but let me just mention that acid treatment is not the treatment for IPF. If there's coincidental GERD, which will aggravate the presentation of the illness, would be treated, but it's not a treatment of IPF. And then you look at treating the comorbidities. Next slide, please. Next slide, please. So my take home, the key points are that coronary vascular diseases related ILD is common. IPF is rare but can be lethal. There is increasing recognition of progressive pulmonary fibrosis complicating diffuse parenchymal lung diseases. The approach to, and I would like to mention here, hypersensitive pneumonitis is not common but well recognized and responds to withdrawal of the aggravating factor. So that's an important one to pick up as well. The approach to ILD includes a careful history and physical examination with a focus on identifying an etiology for the ILD. So questionnaires are often used to identify any environmental or drug exposure. Then multidisciplinary discussion is an essential part of the diagnostic evaluation, usually between the pulmonologist, the radiologist, and the pathologist. And then decisions regarding a diagnostic and therapeutic approach must be individualized to the patient's needs and disease. So at this, I would end my presentation. Thank you very much.
Thank you so much, Dr. Kosom, for such a
Thank you.
In the interest of time, I will invite the next speaker, who is Dr. Kevin Ombati. Dr. Kevin Ombati is a thoracic radiologist, and he's an assistant professor in cardiothoracic radiology from the Aga Khan University Hospital, which is one of our private facilities here in Kenya. Welcome, Prof. Ombati.
Thank you, Dr. Katima, for the introduction, and thank you, BI, for giving me this opportunity to have these discussions with the team that's here and those who are online. So I will be talking about radiological evidence of pulmonary fibrosis in rheumatoid arthritis associated ILD, and even beyond just the interstitial pneumonia. What we look at is some of the radiological manifestations of patients who present to us. So the disclosure I have is that I've been contracted by BI to conduct this session, and I have no financial interest in BI. So I'll quickly go into respiratory arthritis associated interstitial lung disease. So respiratory symptoms, and that's the reason I believe we're all here, is that a lot of these patients will develop respiratory symptoms and will have thoracic manifestations even on imaging. And depending on the type of study you do, methodology, the patient population, it has been reported that even up to 60%, 60 to 80% of patients with rheumatoid arthritis will develop some form of thoracic manifestations. And we'll look at some of the examples, but concentrating on how pulmonary fibrosis presents in these patients. One aspect is that sometimes the respiratory symptoms may even precede the articular symptoms. In radiology, in rheumatoid arthritis, most of the time, if you mention that, somebody will think about the joints. But in some patients, the very first presentation might be the pulmonary manifestation. Then that's why we should all have a high level of suspicion, especially in those patients who have some interstitial lung disease, no other explanation, and on further workup, you start suspecting rheumatoid arthritis. Then you'll know that whatever you're seeing in the lungs is perhaps related to the rheumatoid arthritis. An issue again is that some of these pulmonary findings may be masked by poor functional status. You might think that the fatigue, the difficulty in breathing, or is perhaps maybe related to the arthritis, but it's in many cases you find that it's actually the pulmonary manifestations that's causing this. There's a high prevalence of pulmonary fibrosis, which mostly manifests as UIP in patients with rheumatoid arthritis. And whether or not, because in UIP, we always look for the subpleural cysts, honeycomb traction bronchiectasis. But if a patient has this traction bronchiectasis and honeycombing, whether or not it fits into the picture of UIP, those patients will have a worse prognosis and poor survival status. So these are some of the HRCT examples of ILDs that are associated with rheumatoid arthritis, but it's okay. I can use the pointer. The most common interstitial lung disease is UIP, as you can see here, and I'll show you some examples. But I believe you're all familiar with the presentation, the imaging presentation of UIP, where you have apical to basal gradient of disease. You have this honeycombing, subpleural cysts, and traction bronchiectasis. So a large majority of the patients will present with features of UIP. The next common is NSIP, where it's predominantly a ground glass appearance in the lung parenchyma, again with an apical to basal distribution. If it's the fibrotic type, you might end up also with traction bronchiectasis, but of note is that the predominant finding is ground glass attenuation, absence of honeycombing, and the subpleural cyst that you see in UIP. The other presentation is organizing pneumonia. Some of the patients might present with organizing pneumonia, might be due to the rheumatoid arthritis itself, or even the medication that they're taking, or even infections, because some of these medications results in immunosuppression. Then less common presentation is diffuse alveolar damage, which will be a rather rapidly progressive disease. And even other less common presentation is LIP, lymphocytic interstitial pneumonia, where patients will have these lung cysts with intervening ground glass attenuation. So there's a whole spectrum of pulmonary manifestations. You'll either have parenchymal interstitial lung disease, you might present with pulmonary nodules, you might present with pleural thickening or pleural effusions, or you can also have airways disease, and this is both upper and lower respiratory tract. You can get involvement of these areas, and it'll end up with the manifestations that you see. And then also, we also remember you can have vasculitis. The pulmonary vessels might also be involved in rheumatoid arthritis, and patients end up with pulmonary hypertension. So the slide here just shows you how all these manifestations come about. Could be due to the chronic immune activation, could be due to the immunosuppression from the medication, or direct toxicity from the medication. So there's a whole list of various diseases that fall under all that classification. But it's important to remember that it's the parenchyma, the pleura, the airways, and then the vascular structures, and there are other conditions such as you might end up with thromboembolic disease or thoracic cage restriction, and even an increased risk of malignancies. So how does lung fibrosis look on imaging? In radiology, HRCT, normal lungs are black, or you see the air. As example, in these CT images that you're seeing, you can actually see the air surrounding the patient, that black appearance. So as you graduate and you see the difference, structures will appear differently in CT based on the density of those structures. So ranging all the way from air, which is black, to bones, which are white, or metallic objects in your body. So you'll expect a normal lung parenchyma to appear black like this. But now when you have infiltration, fibrosis, you see that white appearance, and it can either be linear within the interstitium or within the parenchyma itself. You'll end up with either ground glass attenuation all the way to consolidation, as shown in this those two images. So the most common manifestation we said was UIP, and UIP will present like this, where you have these subpleural cysts, and also honeycombing, and you have traction bronchiectasis, such as in this case. So, and the traction bronchiectasis will usually be the cylindrical type, although some you might have some cystic appearance of bronchiectasis. So that was to do that image shows you both the lower respiratory tract involvement, your bronchiectasis, and also shows you some parenchymal involvement, the reticulations. The other, remember, in some patients who come with radiographs, you might see some of these manifestations on a simple chest radiograph. And again, on this chest radiograph, it shows you the reticulations. As you can see on this chest radiograph here on the right, you can see the reticulations, predominantly basal in the where they're located, and in this patient, you can also appreciate some level of pleural thickening. The other patient on the left is a different patient with more extensive reticulation, but of note is that this patient also has nodules, quite a common presentation of patients with rheumatoid arthritis. And in some of those nodules, which might be necrobiotic, cavitating, just subpleural, you'll end up with pneumothoraces in some of these patients. So for example, here you can see this is a patient with a pleural effusion, but one of the nodules, the cavitating nodules, actually leaked and caused this, you have a rupture of the necrobiotic nodule and you end up with this hydropneumothorax as in this patient right here. So the other finding, apart from effusions, you can also have pleural thickening. Lots of people sometimes might confuse pleural thickening with effusions, but this will be persistent over a long period of time. You can also use ultrasound to confirm this on the bedside. So you can see that example here, very good example of pleural thickening. But of note, you can see this patient already has had shoulder joint prosthesis due to the rheumatoid arthritis. This is just a CT chest of the same patient showing you the pleural thickening. And it's not an effusion. If these are lung windows, but if it was soft tissue windows, you'll have seen the difference between pleural thickening and fluid, quite different. And you can also see the associated parenchymal bands right there. This is another chest radiograph, again showing you have the fibrotic changes at the lung bases. Again, this patient developed a pneumothorax and has bilateral pleural effusions as demonstrated. So UIP, we've covered that, is the most common presentation of rheumatoid arthritis, interstitial lung disease. And this was just another example showing you the typical appearance, typical distribution, predominant findings. Then in some of the patients with UIP pattern, remember there's increased risk in smokers. This is an example of a patient with emphysema. Sometimes you might get combined pulmonary fibrosis and emphysema in such patients. So it will present as this, as you're seeing here. So given the history, you're seeing a UAP pattern, but again, also look for other concurrent findings. With the lower respiratory tract, remember, as we said, it can also be involved in this rheumatoid arthritis, and it will present, you might not see the bronchial wall thickening of the terminal bronchioles, but what you might see is the mosaic lung attenuation. So remember, I said that, we had said that sometimes the black lung is normal and white lung is abnormal, but sometimes that's not the case. For example, here, the black lung represents areas of air trapping due to the bronchial wall thickening. So in patients with, for example, this, when you have it involving the lower respiratory tract, the presentation might just be this mosaic lung attenuation, and you can do this by doing an inspiratory and expiratory chest CTs. This you can discuss with the radiologists. It's quite easy. There should be no additional cost to your patients, just additional radiation, unfortunately. The other aspect to think about is not just the obliterative bronchiolitis, but you can also have follicular bronchiolitis. And this comes as a result of hyperplasia of the bronchus-associated lymphatic tissue. So the difference here is that, yes, you might still have the mosaic lung attenuation as you see, but if you're not closely, is that you also have these centrilobular ground glass nodules, which also represent these areas that have this hyperplasia of the BLT. Now we have PET-CT increasingly becoming common in Kenya. We have 2 centers, and I hear 2 more centers, I think 3 centers, Dr. Onyeka, if I'm not wrong. And I've heard that other 2 centers also planning on having PET-CT. So we'll probably have a total of 5 PET-CTs in Nairobi very soon. So this is again something that you can use to monitor your patients. Remember, if they have extensive fibrosis, they'll end up with pulmonary hypertension. And one aspect is that you can see there's active uptake in the right ventricular free wall because of that increased pressure. And again, within the lung parenchyma itself, in the areas that have fibrosis, you also have increased FDG uptake, meaning that there's increased metabolic activity in those areas. You can use this to monitor and follow up your patients and also rule out other conditions such as malignancies. So looking at pulmonary fibrosis, we'll end up with pulmonary hypertension. So an easy way is to look at the size of the pulmonary arteries. in the absence of previous pulmonary embolism. This could also be, you could have, it's either vascular causes or pulmonary parenchymal causes. So in patients with extensive fibrosis, they'll end up with pulmonary hypertension, which on imaging will appear as dilated pulmonary arteries. The cutoffs that we use are 30 for male and 29 for female. But also it's important and very easy, useful to compare with the ascending aorta. That ratio should not be greater than 1. Thank you.
You want to?
All right, thank you so much, Dr. Mbati. I will invite our next speaker. Our next speaker is Prof. Bwika. Prof. Bwika is the head of pulmonology at the Aga Khan University Hospital, which is one of our private facilities. He's also the president of the Respiratory Society of Kenya, and he was the one who heads the pulmonology at Aga Khan. Karibu sana, Prof. Bwika.
You want to use this? Is it the one that you shared just right now? You have changed the one that you shared a few minutes ago. Okay. Hi. Is it okay? Changes? Yeah. We ready to work? Yeah, do you want to work?
Well, you just do for the online.
Yeah.
That's sure. You'll be changing slides.
Okay. This is the next time. Now we'll continue to share. I hope there is no much difference.
Okay. Cheers. Okay, thank you for that. Sorry for disrupting your flow of slides. I've been asked to talk about the move from clinical trials to clinical practice. I interpreted that to mean how pertinent is clinical trial data to clinical practice. So I am a clinician working in an academic institution. What I want is what clinical trial data comes is relevant to what I do. And so I'll basically, in no specific order, talk about the history of ILD in my own recent memory, what places they are in designing and performing clinical trials, and how applicable they are to clinical practice, and just a little bit about specific challenges we have here in Africa. Okay, so what we want from a clinical trial, the desirable outcomes are that the data is generalizable to the population we serve as clinicians, that we get important safety information about the intervention being done or being offered, that the intervention is efficacious. It actually does. It influences, it impacts the endpoint, the clinical endpoints that we are looking at in a significant manner, that it is effective. You could do a drug trial on an intervention that requires quite a lot of preparation. For instance, you need to take the medication on an empty stomach and then wait half an hour and then take a very heavy lipid-rich diet for it to work. So if that was the intervention in the clinical trial, is that reproducible? In real life, will people actually take the intervention the way it was taken during the clinical trial? In which case, it affects the outcomes in clinical practice. And how relevant are the endpoints to the clinician? So I remember a time when interstitial lung diseases were either extrinsic allergic alveolitis or cryptogenic fibrosing alveolitis, and there wasn't much else in between those. And everybody thought that it is a chronic inflammatory process that is causing damage to lungs, and hence the issue is inflammation, and treating inflammation will help. That perhaps was a reason why corticosteroids started perhaps in the 50s, in the 1950s, to be used in treating pulmonary fibrosis, especially idiopathic ones. More recently, there was a trial in which they were looked at. Well, it was some trial in 1990s, and they showed a 12% improvement in patients when steroids were used. And then there is a trial in which the standard practice, which at that time was prednisolone, was compared to prednisolone plus azathioprine, and that again showed a modest functional improvement and better survival. So that was Ragu et al. In 1991. So the important thing is that the better people understand pathogenesis, the better people understand the pathology, the better interventions are designed, and perhaps the better the outcomes. You can see through here that initially, as we said, people thought it was all just inflammation, and they used steroids. And then people understood things better and better, and we had better and better interventions being discovered and being developed and being trialed, and better outcomes over time. And we hope that this will continue the better we understand the pathophysiology of these conditions, interstitial lung diseases. And the role of precision medicine and genetics is becoming more apparent, and hopefully we'll see this featuring in trials regarding interstitial lung disease treatments. So the mist that surrounded interstitial lung diseases before the Panther trial was such that people really didn't know whether to treat or not to treat. And the American Thoracic Society issued a statement in 2000 in which they said there is no requirement to treat. In short, there's no requirement to treat these conditions if the treatment you're going to offer is going to cause harm. Okay, so people had to engage brain and decide who to treat, and because we couldn't really discern autoimmune-driven ILDs from idiopathic ones at the very beginning, it was some people got steroids and got better. Some got steroids and didn't get better, actually got worse. And we know ILDs can present with the pulmonary fibrosis before they manifest with autoimmune or connective tissue disorders clinically. So then there came this introduction of N-acetylcysteine treatments. So the understanding was that oxygen radicals were important in the pathophysiology, and using an antioxidant, in this case N-acetylcysteine, which is a precursor of glutathione, will perhaps help. So the Iphigenia trial was born, and they had on one arm standard therapy, which then was azathioprine and steroids, versus the same plus N-acetylcysteine. And they used vital capacity and DLCO as primary endpoints to show decline in lung function. And they demonstrated some improvement when you used when you added N-acetylcysteine to the standard therapy then. And perhaps that was a mainstay for the triple therapy. So I grew up using triple therapy to treat IPF until the Panther IPF trial. So the Panther IPF trial randomized patients to the triple therapy on one hand and to prednisolone, N-acetylcysteine on the other. So, and then there was a N-acetylcysteine plus placebo. And the aim was to demonstrate a reduction in a loss of lung function, and they had a change in FVC in 60 weeks as a primary endpoint, and many other secondary endpoints. And that's basically the consort chart for it. And they had a planned midpoint interim analysis, like many RCTs may have. And during this, they actually demonstrated that there was no difference at all in loss of lung function, in FVC loss between the two arms. But in actual fact, there was worse outcomes in the new intervention, or in the triple therapy intervention. They found more adverse effects, and more concerning deaths were more, 10% to 1%. So that was enough to stop the trial. And that's when people realized that in actual fact, triple therapy was harmful. This was a proper trial with blinding, with placebos. The Iphigenia trial didn't have, it wasn't placebo controlled. Now, after that, there have been further trials, and you can see they use reasonable endpoints, and you can see they had good outcomes, and this basically just shows you the number of trials there have been for idiopathic ILDs, and the larger the circle, the bigger the sample size, and some of them have been talked about by the previous presenter, and some will be talked about later. This is basically to show that pathogenesis helps guide drug development, helps inform endpoints, and helps as a basis for very good trials and proper outcomes. Genetics have started featuring in interstitial lung disease. So for instance, the short telomeres are associated with earlier disease and quicker decline in function. And perhaps that's an important thing to consider when we're going into drug development. It's important to consider this when you're randomizing patients to different treatment arms, because as we know, ILD patients are heterogeneous, and there may be intrinsic factors amongst the patients that influence their progression of the disease, never mind what the intervention is being given in the trial. So this is an important piece of discovery that needs to be built into clinical trials going forward. And we know that we already have quite a number of challenges with clinical trials, with design. So we've talked about heterogeneity. We're talking about patient recruitment. This is a fairly common condition, but when you look at the power calculations, the number of patients you need to build a good enough clinical trial makes it difficult. We talk about clinically relevant endpoints. Clinically relevant endpoints may require a lot of questionnaires that you ask patients, and repeated questioning of the patients make them find the trial tedious, and patient retention can be an issue as well. So there is at the bottom there's an example of people trying to recruit patients into trials from 2 registries in Canada, and they struggled to get the right patients for those trials. And the data shows that only between 29 and 64% of registry patients or registry populations fit into most clinical trials. And registry patients actually are a really good population for clinical trials. This just highlights the challenges patients get when they are on clinical trials that leads to attrition of patients in clinical trials. So we come to the issue of clinically relevant endpoints. You are doing a trial looking at black seed intervention for IPF, and you want to show that that actually works. How do I, as a clinician, rate the trial? I want you to tell me that the endpoints actually correlate very well to what I want. As a clinician, I want to know how a patient feels. You have ILD, how do you feel about it? What are your symptoms? Are you better after this intervention 52 weeks later? How well do you function as a patient? Okay, and survival, mortality, and that's the key endpoint. And we all tell our patients from the time of diagnosis, your median survival is 3 to 5 years, and all that. The patient says, well, what can you do about that? I want to live longer than 3 to 5 years. How do I tell them? This trial showed that if you give somebody this intervention, you change that from 3 to 5 years to this number of years. And what trial tells you that? So that is clinically relevant endpoint that we want. So here we look at Raghu et al. Did a paper that was actually a bit controversial, but I think there are take-home messages from this. So all-cause mortality is important. And that's the key thing. Everybody wants to live longer. So all-cause mortality as a clinically relevant endpoint in clinical trials is important. Some people talk about respiratory-related mortality or IPF-related mortality, but perhaps all-cause mortality is what is most important, given that IPF causes death, and some of it could be not IPF-related. And then a time to an event versus an endpoint at 1 year those are other useful endpoints you can use. So, for instance, time to admission, time to an acute exacerbation of the condition in question, versus an endpoint at 1 year. So you do the trial and then assess the endpoint 52 years later. What about acute exacerbation of IPF? That's important because that's one of those common things that actually worsen progression of the condition. The problem of that is challenging because in a clinical trial situation that needs to be adjudicated, you need to all agree that what is being described as an acute exacerbation is indeed one, and not just a pneumonia, a bronchitis, or something else. So that then can challenge utility of acute exacerbation of IPF as an endpoint, just because of the delays taken. And trials which are multinational or international need to have a central adjudication committee, and that can be a challenge. Patient-reported outcomes are good. They can be problematic, but they will be good because we said what the patient feels. That's what you want. But there can be a challenge in agreeing in how objective patient-related outcomes are. Functional status, we've agreed, is important. What is the ideal measure of functional status? So we've used VC, we've used FVC, we've used DLCO, which is fine. But what about FVC? Change in FVC per group, average change at the end of the trial? Or what about time to, how long it takes to reach a certain cutoff? For instance, 5 to 10% change in FVC, how long it takes to delay the reduction in FVC by that, or DLCO for that matter. So that we don't seem to know what is a more important way of looking at this functional status. The other thing is about surrogate endpoints. So surrogate endpoints, in essence, just describes what we've been talking about. So here we have a schema from Raghu et al. And A is an accurate surrogate endpoint. You have a disease, you give an intervention, and then you affect the surrogate endpoint and also affect the clinically meaningful endpoint likewise. So disability, for instance, is my clinically relevant endpoint. If I can demonstrate a reduction in FVC by this amount, it actually correlates to a change in the anticipated disability by an equivalent amount. That is an accurate endpoint, surrogate. But then you have surrogates in which the intervention only affects the clinically meaningful endpoint without affecting the measured endpoint in the trial, and vice versa. And this may be due to the underlying pathogenesis, that there may be one pathogenetic pathway leading to that affects the endpoint, or there may be more than one and you only treat one and not affect the other. So getting the ideal surrogate for a clinically relevant endpoint is important. Perhaps we learn this with more trials and with more research, but these are things that people need to look at when they are interpreting clinical trial data. And secondary endpoints are important because they complete the picture. They have their own intrinsic problems, like power calculation. They have problems with the missing data. Our notes are not that robust. They basically make the trials bulkier because they're collecting so much data that influences the duration of the trial, the cost of the trial, and the rest of it. So let's look at what we have. Why are we here? What do we have? What clinical trials have changed our practice recently? So we have all these that we have seen: impulses, senses, and inbuild. For impulses, those were the endpoints. The primary endpoint was about functional status. So it was FVC, change in FVC ml per year. The key secondary endpoints were time to acute exacerbation, and this again was investigator reported, and change from baseline in the St. George's Respiratory Questionnaire over 52 weeks. So these were the key inclusion criteria, okay? And these were the results in terms of change in FVC in patients with IPF over time, so clinically significant over 52 weeks. So mean for one group versus mean for the other. The cause of IPF, this is about the acute exacerbations, and they said in the trials that there was proper adjudication of the acute exacerbations. There you go, and there was a statistically significant reduction in number of acute exacerbations. And this is about why they did a trial on SSA ILD and progressing fibrosing alveolitis. ILDs. And you can see the two datas for the two trials. And there has been some discussion about the take-home message about use of nintedanib on the basis of the subgroup analysis for the inbuild trial. And this again all rests on power calculations. But I think, in fairness, the authors said that all it shows is that, in actual fact, nintedanib has value in any ILD that seems to pursue a progressive fibrosing nature, and not necessarily zero it in on a specific subgroup. On the right, there is a different Japanese trial that did show intervention that influenced the rate of decline in the progressive fibrosing ILDs. So here you have the primary and the secondary data, endpoints for that trial, for that's inbuild. So we come to Africa. How relevant is all this to us? So we know we work and live in different socioeconomic climate compared to quite a number of these economies from which this trial data comes. And we have different health systems. Our genetics are different as they are for the other different continents and different countries. And we have different environmental and occupational exposures. So it's natural to expect that some of the ILDs we see are perhaps peculiar to our populations, to our economies, to our patient populations. as compared to the others. And we already started by saying ILD is a heterogeneous group of diseases. So it makes sense to expect that we may have ILDs that behave and respond differently to different interventions. I don't know that for a fact, but nobody knows otherwise. We have different diagnostic pathways, different management pathways, and we allocate resources differently. And just here in Kenya, where Dr. Wanjiku practices is very different from where Dr. Alwat practices. The populations are different. The interventions are going to be different. Diagnostic pathways are going to be different. How you end up with a diagnosis depends on those diagnostic pathways. And that perhaps informs why we have this national ILD MDT, which was, I think, a genius move. So thank you very much to all those people, Dr. Atina et al., who came up with that. So local data informs clinical practice guidelines. And this is basically a statement saying that we need to do more in terms of research, whether descriptive or clinical drug trials. We need to do research. We need to generate data about what we have. And we hope that the National ILD MDT will be perhaps a substrate for our registry as well. Last year I was asked to talk in the PATS conference about where is the data in ILD, and I did a troll, and there's very, very little data on ILD in Africa. It's very little. You can actually fit it on 2 slides, 2 PowerPoint slides. And perhaps you can get information from health and demographic surveillance systems. But we started by saying even ILD registries can only offer up between 30 and 50% of appropriate patients for clinical trials. So just going into a health or a demographic surveillance system, you can get something, but I think what you get is also very little. So we need to have registries. We need to think about biobanks. Okay, we need to increase the research capacity. We need to increase research competence amongst ourselves and affinity for it, that we are actually thinking and working towards this. So that is the conclusions. The key take-home message are that drug discoveries are informed by our understanding of pathogenesis, of pathology, of demographics, and the rest of it. We're not doing enough of that. We need to do more. That safer and more effective treatments can be gotten with precision medicine and closer attention to and use of genetics in translational research. And also we need to pay closer attention to translational research. Is the research relevant to the consuming clinical practitioners? We need wider and more in-depth consultative decisions on important drug trial endpoints. So is FVC really a good endpoint for outcomes? If so, how should we interpret FVC and the rest of it? And we need to build our research capacity. And that brings me to the end of it. Thank you.
Another round of applause for Prof. Bika. That was an amazing lecture. Okay, so we now have gone into a Q&A session for our 3 speakers before we go to session 2. I will open up, Prof. Is there a microphone going around?
Yes.
And also someone keep online viewers, please, looking at your questions, you can put them on the chat.
Thank you very much.
Or the Q&A. Put them on the Q&A so that they're all together, please.
Excellent discussions and presentation. There was one thing I was looking forward to hearing, but it doesn't look like any of the 3 speakers have mentioned it, which is now playing a major role in diagnosis, management, and prognostic features in ILD, and that is AI, and particularly machine learning and deep learning. So I think the radiologist should have told us more about, because after all, it's now known that AI is better than the radiologist in interpreting the HSCT features, because we know very well there's so much inter-observer and observer variation and inconsistency and false readings and false in radiology if they read it. So the AI has overtaken them in the reading of these things. So really, there's no way you can talk about radiology and ILD without referring to AI, and particularly the sub type of AI that is machine learning and deep learning, which is now standard in the ILD diagnosis. The same thing, Dr. Boyga should have also told us that we now use AI in prognostics and telling the trend and how well the treatment is going to work without you doing so much research as you're imagining. And even in clinical diagnosis, early diagnosis and management. So can you just comment on what you know about AI?
So thank you, Prof. Oloch. In radiology, it's true we cannot avoid speaking about AI. I intentionally left it out because it's a whole huge topic on itself. But in our current scenario, even I'm not surprised that question has come up. So what we use AI or computer-aided diagnosis, it's more advanced in the infections. So, for example, there are very good softwares that can pick out TB, and they're used in screening programs, or even people who want to travel outside. There are some companies that use that for visa purposes. It's also not just TB, but also other pneumonias and say fractures. It can pick them quite well. But in interstitial lung diseases, it's still developing. And what you're talking about, machine learning, it has to be fed frequently and continuously for it to become better and better. It keeps on getting better and better. But it can be used, for example, in fibrosis scoring, looking at quantification. Yes, what radiologists we use currently is a subjective way of quantifying fibrosis amount or quantity of fibrosis in a HRCT, for example. But there are already AI softwares that can even help you to quantify the amount of fibrosis. But also there are some tools that now can attempt to differentiate the different type of interstitial lung diseases.
Well, we now know that whatever you got many patterns. That's why AI is also very useful in diagnosing some of the dermatological situation where you've got many features, photos, or patterns. AI is better in isolating. If you use the algorithms, the AI is better in helping you to diagnose some of those things, because they can, with machine learning, improves with the time, as we know, without having to be reprogrammed. So I think it's time that we adopt it in our usual practice, rather than say some talk about it as a novelty.
So it's a question for you. It's more of a comment than a question. I mean, firstly, thanks for an excellent presentation, Prof. Boyke. Don't you think that it's disappointing that all of our evidence for randomized control evidence comes from IPF and scleroderma? And in fact, for most of the other interstitial lung diseases, we've got very little in the way of high quality evidence. It seems like those two diseases have really been prioritized above all others. And it's, you know, when you do go looking for evidence for the other diseases, it's pretty scant. I'm sorry to say that I think you stole most of the thunder from my presentation, which is also on guidelines. But I think one of the major problems in ILD is that we've got a dearth of good quality data outside of scleroderma and IPF.
Yes, I agree. And I think the rationale in my research, in my reading, the rationale is that IPF is the most fatal of all idiopathic interstitial lung diseases. So it makes sense to put more resource in it. But you're right, there's still quite a lot of death and suffering outside IPF. And you're right. I think even if you looked at how much research there is on IPF, for instance, compared to something more mainstream, is still not enough. Never mind for everything else. And I agree with you completely about that. And I think in my clinical practice, managing ILD is more expensive than it is to manage TB and pneumonia or even asthma for that reason. So I can imagine what the cost and the intricacies and the rest of it there is in doing interstitial lung disease research. So perhaps that's the reason for it. But I know when it comes to new things, we always say best things since sliced bread, and AI is probably going to change how we manage, how we work as clinicians. But as Kevin said, I think you move from one to the other, and I think WHO did very well to use computer-assisted diagnosis in the algorithms for tuberculosis. But how has that happened in Kenya? Does that happen in Kenya?
Yes, it does.
Yeah, but where does it happen?
Just the other day, I organized a medical camp in my village, and with the use of AMREF and the digital X-ray, we were able within 90 seconds to do the X-ray and get a report.
Is that in mainstream clinical research outside a camp?
No, this is not research. This is a medical camp. Just a routine.
You know what I mean is, if you go to your village now, or my village in Kinango there, will you find these things working?
Yes, Professor Buika, it's been also established that AI is even more useful in low and mid-income countries to improve the diagnosis and maintain the Millennium Goals. Been shown clearly.
No, I'm not arguing against that. I'm just saying.
So it should be available.
Yeah, that's the practice.
It should be available.
How accessible is it going to be?
But when you talk about having IT, connection in the village, then you can use half the others. And it's really, most places have got IT. But that's like a discussion for another day.
Yeah. But just a quick one. What we're working on as Kenya Association of Radiology is to develop policies regarding AI, because remember, it's not appropriate to use the AI tool and give that report as a final report. It still has to be read by a radiologist. So what it's used in aiding and screening and making our work faster, but one needs to be very careful not to release that AI-generated report directly to the patient without passing through a radiologist. So we are in the process of working around a policy document that will streamline and guide the use of AI in radiology in Kenya.
I think Prof.
Let me just make a comment, on the AI business. I think in a few years' time, we'll not have doctors meeting again. We're probably going to have AI software engineers meeting rather than human beings meeting. China has just opened a hospital where it's all AI, and therefore a lot of doctors were all going to be redundant. So let us just keep hoping that will not come so soon.
In the city of Nairobi, there are patients who cannot afford a salbutamol inhaler, PMDI. They are on oral salbutamol tablets. I think that's more important than AI.
Any other?
Yeah, it's our topic.
Okay, it was wonderful presentations from both the speakers. This is a comment. I feel also we should embrace lung ultrasound. It has been shown to really pick the interstitial lung disease patterns early, and especially maybe in replacement of the II, which is awaiting. I feel if we train more in terms of lung ultrasound, we are able to pick at a low cost, and even maybe just do a follow-up of HRCT, maybe just a year or 3 years. So yeah, lung ultrasound. The second point is in part of your the research that was done, was there any quality of life measures? Because what we realize, we assure our patients that you're on nintedanib, the fibrosis is not progressing, but this patient quality of life, the cough is not going, the dyspnea, the quality of life is still not good, and we are stuck as clinicians. Like, what next should we do? This patient is still having a dry cough. You've put on the maximum medication. So such things there.
Yeah, for lung ultrasound, I totally agree with you. And I also mentioned it there. For example, we use it to differentiate between pleural thickening, pleural effusions, but also consolidation is very important because I've seen cases, especially with a chest radiograph, a chest tube was placed in, but nothing drained, or you can understand where I'm heading to. And if a lung ultrasound was performed even at the time of putting in the tube, then that decision would not have happened. So, and it's quite a useful tool, even in interstitial lung disease like septal thickening can also be seen on ultrasound, and quite important in very short-term follow-up to avoid inadvertent or unnecessary exposure to radiation.
Okay, so quality of life tends to feature a lot more in the secondary endpoints. There are quite a number of questionnaires that capture that.
Any other question before we move on to the next session in the interest of time? I don't see any questions online, so thank you so much. Let's give them a round of applause. We are running a little behind, so I will introduce the moderator of the next session. We are going West Africa now. The moderator is Prof. Olufemi Adelowo. I hope I've pronounced it the correct way. Professor Femi Adelowo is a professor of medicine and consultant rheumatologist. He graduated from the University of Ibadan Medical School in 1973. He had his residency in internal medicine and rheumatology at UCH Ibadan and St. Bartholomew Hospital, London. He completed in 1982 with an FMCP, thus becoming the first physician in West Africa to specialize in this specialty. He was also the first African professor of rheumatology. We are honored. He also has other fellowship awards, FWACP, FRCP Edinburgh, FRCP London, FACR. He has the highest award in rheumatology specialty, Master Rheumatologist of the American College of Rheumatology. He was the foundation vice president of the African League of Associations of Rheumatology, AFLA, 1989 to 1994, and is the current president of the association. He is the immediate past chairman of the World Body of Rheumatologists, that's ILA. He has worked and lectured at UCH Ibadan, University of Lorin Teaching Hospital, Lorin Onabanjo University Hospital. Yeah, that's in Sultan Qaboos University Hospital. Welcome, Prof.
Thank you so much for inviting me to this historic city of Nairobi. This is my fourth time, and each time I come, there are two things I want to do. One is to go on safari. The other one is to go to carnival. And of all the 4 times I've gone on safari, it was only last year when I came for the AFLA that I saw some bad lionesses, bad sisters who are just killing other animals, and they were not eating them, you know. So that was memorable for me. So thank you so much. And my co-chair is Dr. Zifa Day from Ghana. I think, you know, she's the current president of AFLA. And for those who don't know, AFLA is Association of the African League of Associations for Rheumatology. Every region has its own regional group. You have EULA, which is the European group. You have ACR, American College. You have PANLA, which is the Asian. Which is South America, and you have the APLA, which is the Asian. So she's the current president of AFLA. She trained in rheumatology with Professor Girish Modi in South Africa, and she's presently a senior lecturer at the University of Ghana Medical School and the teaching hospital. She has quite a lot of publications. Her main interest is in lupus, and presently she's also the president of a support group lupus initiative in Ghana. So you should be talking on why CTD-ILDs are important and what are the screening strategies for CTD-ILD. Dr. Sifade, please.
Thank you very much, Professor Adelu, for that kind introduction. And thank you to Moringa Edenheim for inviting me. I'm sorry I couldn't be there physically. Now, today we're talking about how connective tissue disease, associated lung disease, why they are important, and what screening strategies we can adopt to be able to identify these diseases. My objectives are to look at what connective tissue disease ILDs are, their presentations, histological subtypes and radiographic subtypes, and the diagnostic pathway. I have no disclosures except the fact that I've been contracted by Moringa Edenheim to make this talk. Now, a few definitions as we go along. Interstitial lung disease, as has been alluded to by some of the previous speakers, is damage to the lung parenchyma evidenced by varying degrees of inflammation and lung fibrosis. There are a group of diseases that have generalized involvement of lung interstitium, and there are over 200 of such diseases that have been described. They are labeled as ILD because of the common clinical, radiographical, and histological manifestations. For the sake of time that have been allotted to, I am not describing connective tissue diseases in detail, but just for us to remember that they are a group of diseases with abnormalities in the collagen and elastin holding tissues, which usually have antibody formation, causing damage to multiple systems. And some of these, which also have lung involvements, include your systemic sclerosis, rheumatoid arthritis, lupus, polymyositis, and dermatomyositis. So what's our connective tissue disease, interstitial lung disease? These are connective tissues that have evidence of interstitial lung disease demonstrated by CT scans, some of which have a combination of reticulation, ground glass opacities, truncation, bronchiectasis, honeycombing, or cysts in the setting of an established connective tissue disease. In order to make this diagnosis, you have to rule out other parenchymal lung disease, such as infections, drug-induced disease, malignancies, and other idiopathic or interstitial lung diseases in such patients. So some of the diseases that result in connective tissue associated lung disease include the systemic sclerosis, primary Sjogren's, rheumatoid arthritis, systemic lupus erythematosus, or idiopathic inflammatory arthritis such as dermatomyositis and polymyositis, mixed connective tissue disease, ANCA-associated vasculitis, and ankylosing spondylitis less commonly. As part of this subclassification, we need to remember as well that there's an entity that has been described called interstitial pneumonia with autoimmune features, or IPAF. These are patients with interstitial lung disease, clinical, serological, and radiographic features which suggest connective tissue disease, interstitial lung disease, but do not meet the established diagnostic criteria for such. It's a term that has been proposed by the American Thoracic Society, European Respiratory Society, as a research term for patients that fall into this category, allowing for standardization of diagnosis so that these patients can be studied further. Among these patients, your NSAP and UIP are the most common radiographical patterns, and treatment is based on their clinical evaluations because there are no randomized control trials that exist in this population. Back to our CTD-ILDs. Lung involvement is seen in about 60 to 80% of patients, and some of this can be clinical or subclinical or not clinically significant at all. In a selected, unselected patients, it can range from about 19 to 67%, depending on the mode in which it was diagnosed. And cumulatively over a 3-year period, incidence can be about 6.8 and lifetime rates about 7.7%. Lung involvement, as has been said in one of the previous speakers, can predate the joint disease in about 20% of subjects in rheumatoid arthritis. And even when the incidence looks like it's stable over time, we know that the prevalence and deaths from interstitial lung disease in patients with rheumatoid arthritis seem to be on the rise. Now back to where we are coming from. How does this pertain to us in Africa? What exactly does it mean for us and the patients that we treat? As Prof said earlier, there's a paucity of publications on connective tissue disease, interstitial lung disease in Africa. Research reviews quite just a little few, but the most prominent among them were articles published by Hakim et al. In Nigeria in 2021 and Palaleni et al. Who described a series in South Africa. Out of these, 31 cases of interstitial lung disease were described among 318 connective tissue disease patients over 7 years in Nigeria, forming 9.7% of their cases. In South Africa, they described 124 connective tissue disease patients. Now, there were some interesting differences between these two groups. Looking at the Nigerian study, 38 points, most of them were younger, and the average age was about 38.8 years, compared to the South African study where they were about 45 years when diagnosed. Predominantly across both of the two countries, the disease seemed to be predominant. However, in the Nigerian study, most of the patients had Sjogren's and systemic sclerosis, compared to the South African study, where majority were female, 86.3, but most of the patients had rheumatoid arthritis followed by systemic sclerosis and other autoimmune diseases combined together. The outcome was dismal, which is the reason why this MDT is quite important, so that we know how best to improve prognosis for our patients, with 12.9% requiring long-term oxygen and 16.1% mortality in these patients. Again, looking at these two studies, in the Nigerian study, most of the patients had rheumatoid arthritis, forming the majority of patients who have CTD. However, if you look at the CTD cohort, they were less likely to develop ILD, that is 2.6%, compared to the South African cohort where they were 29.8%. In the Nigerian study, none of the patients smoked. However, in the South African study, 60.5% of them were smokers, which may also emphasize the evidence that tobacco smoke is a risk factor for interstitial lung disease. And looking at the time of diagnosis, 31.5% of those who were diagnosed with ILD at the time of diagnosis in South Africa. But in the Nigerian study, 74.2% had ILD at the time of diagnosis, suggesting either very late diagnosis or delayed presentation in the Nigerian patients. Again, emphasizing the fact that we need to screen our patients early and diagnose them early, as was seen in the South African study, where most of the patients develop the disease within 3 years of diagnosis. Now let's look at some of the other connective tissue disease and some of the data regarding them. Overall, for systemic sclerosis, which has been described as having some of the highest incidence of cases of ILD, incidence ranges from about 8 to 56 per million cases, and a prevalence of between 38 and 341 cases per million patients. ILD is thought to be more prevalent in patients who have the diffuse type of systemic sclerosis rather than the limited type, even though both of them can develop ILD. When it comes to the idiopathic inflammatory myositis, the incidence is about 1 to 19 per million persons per year, and prevalence of about 1 per 100,000. The incidence in this or the prevalence in this population varies depending on what criteria was used for diagnosis, whether it was HRCT or physiological screening, and ranges from between 9 to 78%. And in 10 to 30% of these patients, ILD can be the first manifestation, again preceding the diagnosis of autoimmune disease by several years. And so a watchful look is important to screen your patients when you diagnose them with ILD. Looking at rheumatoid arthritis, where a lot of these cases are also described, we want to look at what are the risk factors that suggest your patients may develop ILD. There is a strong support for advanced age, smoking, which we know makes rheumatoid arthritis more aggressive, male sex, and high disease activity score. There's weaker support for active disease in anti-CCP levels, methotrexate use, anti-TNF inhibitors, and genetics. Looking at genetics, there's a strong gene risk factor for idiopathic pulmonary fibrosis, which is found in the promoter region of the gene encoding mucin 5B, which is also found in about 32% of patients with ILD, suggesting there might be an overlap genetic risk there. Autoantibodies form a very important part in diagnosis, prognosis, and telling us the long-term outcome of patients who have connective tissue disease. And this obviously shows up in looking at the risk for interstitial lung disease as well. So antibody profile is very important when predicting systemic sclerosis interstitial lung disease. SEL70 is associated with increased risk of ILD compared to the centromere antibodies pattern. Those who have a nucleolar pattern of ANA are also at higher risk of ILD. And these nucleolar patterns are often associated with your anti-TATO and your URMP antibodies, which have also been associated with severe interstitial lung disease. Looking at systemic sclerosis, a higher modified Rodin skin score, which is used to determine how advanced of the fibrotic skin lesion is associated with active or more likely risk of developing ILD. Black rays, high CP, K levels, and cardiac involvement also may predict those who may develop interstitial lung disease. Looking at the genetics of these diseases, there have been genetic associations found in development of ILDs in the idiopathic inflammatory arthritis, myositis, and this has been associated mainly with your HLA, DRB, and HLA-P0801. It's twice as common in females compared to males when it comes to the idiopathic inflammatory arthritis, and is higher incidence in the black race. And so the reason why we should be very concerned as Africans with these conditions. What are the typical symptoms that these patients present with? Unexplained breathlessness, which can be slowly progressive, insidious onset, or acute in some cases. A dry persistent cough is one of the common complaints most of the patients will present with. And on examination, you may find crackles on examination at the lung basis or throughout the lungs. They may have hypoxemia at rest or with activity, and unexplained reduction in exercise capacity. During your lung function test, you may see restrictive pattern or unexplained decrease in the diffuse capacity for carbon dioxide or your DLCO. In the Nigerian study, the most common presentations were cough in 93.5% of cases, bisal crackles in 83.9%, and a restrictive pattern on PFT in 83.9% of cases. This has been talked about briefly, and I'll just go through it briefly. That's one of the diagnostic ways we need to look at is the histological classification. This is important because it gives us the prognosis and the response to therapy for these patients. 7 subtypes have been described: the usual interstitial pneumonia, the non-specific pneumonia, which is the most common pattern found in most connective tissue disease, interstitial lung disease, the desquamative interstitial pneumonia, respiratory bronchiolitis, organizing pneumonia, diffuse alveolar damage, and your lymphoid interstitial pneumonia. Looking at the histology in the NSIP, is typically characterized by homogeneous infiltration of the interstitium by inflammatory cells with varying degrees of fibrosis. And some patients may have more inflammation or more fibrosis or a combination of both. UIP is seen in idiopathic pulmonary fibrosis, but also in connective tissue disease-associated interstitial lung disease. And it's characterized by more lymphoid aggregates and germinal centers with fewer fibroblast foci in CTD compared to your IPF. Organizing pneumonia is characterized by inflammatory cells and fibrotic cells in the connective tissue, alveolar, and distal spaces. This is usually found in patients who have idiopathic myositis, and they may be associated with an NSIP pattern as well. Diffuse alveolar damage is predominantly found in acute exacerbations of ILD and is associated with poor prognosis. This can also be seen in the idiopathic myositis as well, and may be characterized by acute edema, highly membrane formation, and organizing phase with alveolar septal fibrosis and type 2 pneumocyte hyperplasia. This is a histological biopsy showing organizing pneumonia on the background of your NSIP pattern in the lung biopsy from a patient. Now, this slide emphasizes why it's important to know this histological classification of patients, that those with your organizing pneumonia, NSIP, LIP, tend to have more inflammation and respond better to immunosuppressive therapy. UIP, fibrotic, and NSIP in the middle there have more of a fibrotic pattern and tends to respond less to immunosuppressive therapy. And so your emphasis may be on trying to make sure that your fibrotic treatment is instituted. This is just a summary of some of the things we've talked about, the common histological or HLCT findings in these connective tissue diseases. We know for RA it's usually UIP, systemic sclerosis is NSIP, idiopathic inflammatory myositis is usually NSIP with organizing pneumonia. The risk factors as we described previously, and remembering that the prevalence varies depending on the disease subtype, with the highest in the systemic sclerosis group of up to about 50% developing interstitial lung disease. However, if you look at the African data again, this is a little bit different from what has been reported in other parts of the world. In the South African study by Palalini and al., it shows that the usual interstitial pneumonia pattern and NSIP patterns occurred almost similarly in the patients who had rheumatoid arthritis compared to other reports where ILD in rheumatoid arthritis typically shows the UIP pattern in both Caucasians and Black patients, emphasizing the influence of gene and racial differences of phenotypes, and the more reason why we need to do more studies on these diseases on the continent, as Prof. Said earlier on as well. Another usual finding in the South African study was that patients who had UIP demonstrated better lung function than other ILD subtypes, despite this generally accepted association of UIP with worse outcome compared to other histological patterns of ILD. This is quite difficult to explain, just so we may note that there may be other comorbid factors that may also influence some of these prognostic associated or outcomes for some of these patients, especially in patients who have connective tissue disease, because there may be other factors that may affect lung function, such as limitations to physical activity, sarcopenia, where there is muscle wasting and poor function in patients who have interstitial lung disease. And in the South African study, about 33.1% of patients had concurrence or had been diagnosed previously with tuberculosis, and 75.6% of them had GERD also as an associated symptom as well, something that has been reported in the Nigerian study too. What are the other diagnostic things we need to look out for? The chest radiograph may be the easiest for us to do in order not to say all the things that have been said before. All we need to look out for are discrete linear nodular or reticulonodular shadows, usually less than 2 millimeters, diffusely distributed in both lungs. And this may sometimes coalesce and form large nodules. In the advanced stage, fibrosis is extensive, lungs may be shrunken and reduced to volume. But remember, a normal chest X-ray does not exclude interstitial lung disease, and that there may be a reduction in lung function without it. Just a quick glance through some of the patterns on chest X-ray. You may have these linear shadows that you may see. You may have the reticular pattern that may be distributed throughout a net-like pattern. You may have larger nodules that may be distributed in the lungs, and you may also have the combination where you have a reticulonodular shadowing. So you see the nodules and then the reticular patterns there. High resolution CT is usually our diagnostic of choice or the gold standard. And for connective tissue disease ILDs, what we are looking out for your ground glass appearance, reticulonodular shadowing, your honeycombing in the lungs, which may appear as small uniform size cystic spaces, which may represent patent bronchioles in the lungs. There may be traction bronchiectasis, and this may provide some quantitative assessment of lung fibrosis. This is just to show you quickly how some of these may look like on the CT. So this is honeycombing, signet ring appearance, your traction bronchiectasis, lung cysts, and sometimes you may have central lobular emphysema. For connective tissue ILDs, there are 3 findings, radiographical findings, that may be used to identify connective tissue disease ILDs predominantly. Usually you have the anterior lobe sign, which is the concentration of the fibrosis in the upper lobes, relatively sparing the rest of the lobes there. And this has a positive likelihood ratio of about 1.99. There may also be exuberant honeycombing, which is extensive honeycombing in about 70% of the fibrotic areas of the lung. Again, the positive likelihood ratio is about 3.68. And you may also have the straight edge sign, which is the third sign, which is the isolation of fibrosis.
This meeting is being recorded.
NSIP pattern or your UIP pattern is less commonly seen. As has been talked about earlier, in rheumatoid arthritis, the most common subtype is usual IFP, which has been described in other populations, except in the South African study we talked about. In systemic sclerosis, the usual pattern seen is the NSIP pattern, with UIP seen in about 40% of cases. And in the idiopathic inflammatory myositis, usually an overlap of NSIP and organizing pneumonia. There's a picture of a CT showing your NSIP pattern with your diffuse ground glass appearance at base, the UIP with subcystic almost honeycombing pattern in RA. And this is a picture of OP with the background of NSIP that you see in your idiopathic inflammatory myositis. Here to just basically go through some of the common patterns in your primary Sjogren's. Usually you see your LIP pattern. Systemic sclerosis, we've already mentioned, usually the NSIP pattern. Rheumatoid arthritis may show more of your UIP pattern, but maybe some combination. SLE we haven't talked about in detail, but also may have NSIP pattern and the AIP pattern, but may have all other features also, except the LIP pattern. LIP, as you can see, not common in all the others except your primary Sjogren's syndrome. Now, if you look at the right side, you see that there are other disease entities that may also mimic some of these connective tissue diseases that you should be aware of in some of these patients. For example, in lupus, they may have pleural disease, they may have diffuse alveolar hemorrhage that you need to be aware of. And in systemic sclerosis, sometimes it's more of the vasculopathy that may be causing the pulmonary hypertension rather than interstitial lung disease. Pulmonary function test is one of the diagnostic parts you may use. They may be normal in early disease, but usually by diagnosis, their vital capacity, total lung capacity may be reduced, with diffuse capacity or arterial hypoxemia observed in late stages. When you do your lung function test, you may see a restrictive pattern with reduced forced vital capacity, or they may be normal, or you may have a high forced expiratory volume in 1 second. That's your FEV1 over FVC seen. DLCO may also be reduced because of pulmonary vascular disease, so you want to differentiate the two. And there may be signs of airway obstruction, commonly in patients who have rheumatoid arthritis or Sjogren's. In inflammatory myositis, sometimes there might be a reduction in pulmonary function, mainly because of the muscle weakness, with maximal inspiration and expiratory pressures being low rather than the lung capacity. We've also talked about the use of bronchoalveolar lavage, so I'm not going to talk about that in any detail. But remember that it may point to sarcoid or drug-induced pneumonitis, pulmonary eosinophilia, hypersensitivity, pneumonitis, and organizing pneumonia. So it's quite useful to rule out or exclude infections. We may also do transbronchial biopsy in sarcoid, and that may also be useful to allow pathological classification, allowing for diagnosis of the type of ILD. And usually, you should reserve this for patients who are under 60 years of age. Other tests that you use to diagnose these connective tissue diseases, as well as was talked about in the discussion, you may also use lung ultrasound. Ultrasound is becoming quite useful in management and treatment of patients with connective tissue disease. Serum is if you want to diagnose sarcoidosis, liver biopsy if there's hepatitis or sarcoid hepatitis, your ENA panel, your double-stranded DNA for diagnosis of lupus and other connective tissue diseases. Remember, lung involvements may not only be interstitial lung disease, so there are differential diagnoses that you need to keep in mind. That all patients who have lung disease should have their indices of oxygenation checked at rest with activity and overnight to help differentiate some of these variants. Pulmonary hypertension is seen in systemic sclerosis,
Thank you very much for your effusive and elucidative presentation. I just have a little to build up on that in my own presentation, which is about the new guidelines to play. But before I go on, I cannot but recognize one of the founders of the African Rheumatology Group, and Dr. Philip Simani is there. He was one of the founders of African AFLA, and I recognize you, sir. Then, secondly, to inform you that we as rheumatologists, we are actually scavengers. We're in a nation, or we're in a city or a nation of scavenger animals when you go to the for safari. Rheumatologists scavenge every other specialty. So that's why we're coming in, because somebody would ask me, what have you got to do when all you do is treat arthritis? What do you have with this? That's because of the autoimmune aspect, which we handle very well. And the information or the realization that autoimmune disease constitutes a lot of ILD was also about the same time when we in Africa started publishing more on connective tissue disease. So on that basis, let us look at the guidelines. Is this slide? Sorry, 1 minute, okay. So while the 1 minute is going on, so I'm going to talk about two major guidelines. The ones by the British Society of Rheumatology and the one by the Korean Society of Rheumatology. The first one deals from the rheumatologist's point of view. And then the second one deals from the pulmonologist's point of view or the general practitioner point of view. And you may notice some differences in their approach to the development of the guidelines. Suffice also to say that we don't have a guideline for, we don't have guidelines for the systemic autoimmune rheumatic disease and ILD. We're expecting the EULA guideline this year. The ACR did a scope study of guidelines sometime in August 2023. So we are still expecting them. So the ones I'm going to present, the British Society is just a scoping, that is a concept of what they were going to do. So, okay, network, I told you. Well, I'm counting, 5 minutes gone, or 10 minutes. The spelling, Beringer. Your spelling is wrong. Beringer, please. Okay. All right, so there we go. Again, I have no disclosure except that I've been forced to come here to come and give this talk. And my outline will be definitions, incidents, related guidelines, and specific condition guidelines, then PSR guideline, like I mentioned, and the Korean guidelines. Historically, we talk, in fact, I'm asked to talk on CTD, connective tissue disease, which we also historically used to call collagen vascular disease. But do you know what? When we talk of connective tissues, we're actually talking about systemic sclerosis, Sjogren's syndrome, inflammatory myopathies, mixed connective tissue disease, and SLE. That is connective tissue. But we're also now realizing as rheumatologists that we have more than that. So we've a new definition of this group, which we now call systemic autoimmune rheumatic disease. And you will notice that in this, we have now included rheumatoid arthritis, which is not a connective tissue. We have also included ANCA-associated vasculitis, which Dr. Forsen made an allusion to, and we've included ASIA spondyloarthropathy. They all have the same autoimmune components. And so my talk will be mainly on SAILD, which in other abbreviations have been called SAD, although I don't like that word, SAD, systemic autoimmune disease, but it's also called ALD. Now, what's the incidence? It's 15% among all SARDs. That's interstitial lung disease. In the Cameroon study, it was 30%. And in our study, as alluded to, from my center, we have 9.7%, from our studies. Many SARDs, unfortunately, may have radiographic evidence, but no clinical evidence. And this we brought out in one of the case presentations we have this afternoon. Now, Mixed connective tissue disease, about 39 to 72, is so variable, and that shows that we haven't hit it on the head. Then systemic sclerosis, 50%. SLE, and that was borne out in our study from Nigeria, that we have a lower incidence frequency of ILD in SLE and other connective tissue disease minus systemic sclerosis. In fact, our studies show that most of our ILD was from Sjogren syndrome. Screening for ILDs have potential of overdiagnosis because the more you look, the more you see. And the more you see, the more you want to, manage. Whereas it's becoming obvious to us that some of those patients actually may not progress beyond what we've seen, and therefore they really don't need any management. Life expectancy, somebody made an allusion to that, that when you tell patients you're going to live for 5 years because of studies, that's not what a patient wants to hear. He wants to live forever. So quoting a publication and say, this study says 5 years, it's not comforting to any patient. What are the guidelines that have been developed? The ACR, American College of Rheumatology, have a guidance, not yet guidelines, a guidance which they made in 2023. And like I said, we don't really have some published guidelines from the big organizations of rheumatology, the EULAR group and the ACR group. We're expecting the EULAR guideline sometime this year. What are the other ones? The ones that we have from South Africa in 2017, the one that you have in 2017, the update of EULAR recommendation was actually on systemic sclerosis, not on SARDs generally. So I don't know whether we can really call that, whether that can qualify for the general guide. But we have different guidelines. You have idiopathic inflammatory myopathy. There's 2022. They are specific diseases, but not the ones for all the SARD. Now, let's just quickly look through the EULAR recommendations on the management of ILD. And like I said, here is about systemic sclerosis, but this was grouped as ILD in SARD. One, that is screening for ILD patients. Who should we screen? Screening for ILD patients with SARD, especially those with high risk, older age group, critical, gender, smoking history, and specific autoantibodies. Then we need to regularly monitor the loss function test. How regularly it is, we really don't know, but we just know we need to do so. Also, there must be collaboration between rheumatologists, pulmonologists, and radiologists. This was probably well said, in the multidisciplinary approach that everybody's been talking about. It is important that these three groups are on the same page. Pathologists, if you have to do a biopsy, but otherwise, I think clinically, there must be collaboration between the pulmonologists, between the rheumatologists, and between the radiologists. And hence, let me congratulate Boehringer for being able to pull this together. The treatment of ILD in SARD should be individualized because each person has his own comorbidities. Each person has his own preference in terms of what drugs to give. For instance, we find it difficult among our Nigerian patients, young women, even old women, asking them to take cyclophosphamide. Everybody, no matter how old, even at 50, they still need their ovary. Even when they know they can't have any more child, but they still say, please keep my ovary, don't suppress my ovary. So we have difficulty, for instance, in patient acceptance of certain of these drugs. Then the new drugs, some of the patients have read it, and Google is one of the best negative doctors that we have in the world. You'd have told them, to cause X, Y, Z and everything. So patients run away from it. So we need to engage the patients. That's very important. Then the use of immunosuppressive therapy, the number is increasing. Then consideration of antifibrotic agents. NICE in UK, and they're not so nice after all. NICE in UK has recommended the use of antifibrotic like nitadenine. Sorry. No, it's okay with this one. Yeah, okay. In patients with systemic sclerosis, they recommend the use of MMF or cyclophosphamide. Now, there are many more that we can talk about. Therefore, I'll move on to the British Society BSR guideline scope. It's not yet out, but this is the agenda that they have. These are the questions they're going to ask. They're still going to do a lot of literature search, and the group would includes pulmonologists, radiologists, rheumatologists, and even the patients themselves. And they're going to use PICO to make that decision. Population, intervention, comparator, and the outcome. That's what they're going to use, just like in all of these guidelines they're talking about. And this is the journal article that's in the Rheumatology Advice in Practice. This systemic autoimmune rheumatic disease, which we have mentioned, it contains the connective tissue disease and also includes rheumatoid arthritis, which I said is not a connective tissue disease. It includes axial spondyloarthropathy, what people generally will say ankylosing spondylitis. But ankylosing spondylitis means you are seeing the so-called bamboo appearance. We are making a diagnosis without bamboo appearance now because at the early forms of the inflammation, you should be able to initiate treatment. We also includes condition like ANCA-associated vasculitis, which is the small vessel vasculitis. All this can cause the interstitial lung disease, and they are not connected to disease. So that's why we're using the more broad definition. What are the overarching principles? Like in all of the guidelines, who should be screened? That's number one. What tests should be performed? There are quite a few things that have been mentioned today. What tests should be performed should now be localized to the environment you are in. Some of those tests are not available. HRCT scan is not readily available in all centers. And we may have to, for instance, make do with a well done chest X-ray, which if you do digital chest X-ray in certain centers with a good machine. Then determinants of prognosis. How do we determine prognosis? That's something that is difficult. Somebody has made an allusion to the patient's quality of life. If you ask the patient for prognosis, I mean, for us, all we do, we look at data. For the patient, for him, prognosis means I'm getting better, my life is getting better. But if the patient is stuck on oxygen, how can you tell the patient, I'm sure you are doing better? The patient would frown at you because it's not doing better, it's still on oxygen. Then monitoring of complications, and there are complications to be screened for, which we mentioned in a moment. Then at what frequency? Every month, every 3 months? Again, that depends on cost. Pharmacological management of ILD, the number keeps expanding. And presently, we don't know which particular one. We may have to tailor one for every patient. Then we also must recognize, and this is often overlooked, the non-pharmacological or palliative management. That's very essential to tests to perform. There are quite a lot of them. They've gone through them, they've mentioned them. 6-minute walk tests is one thing we use in our clinic. But then for a patient with SSA ILD who has an arthritis, how do you assess the 6-minute walk? Then in our patients with scleroderma, their skin is sometimes so thick you cannot even use the pulse oximeter. So we have some challenges, with that. You tell a patient who has arthritis of the hip joint or the knee joint to walk, you'll be surprised it may not even work for you. So these are some of the challenges. Lung ultrasound, you need the expertise for it. I'm not so sure that is readily available in Africa south of the Sahara. Maybe South Africa. Because South Africa is a completely different population from Africa south of the Sahara. Determinants of prognosis, autoantibody profile. We mentioned a few of them. The lung function test parameters, imaging features on HR, CT chest. There are new CT machines that may be as good as for the HR CT. that may cost less for us. We also need soluble biomarkers. What complications should we screen for? An allusion has been made to pulmonary hypertension. But then there are some other ones. Gastroesophageal reflux disease, which can be so troublesome for the patient, because when the patient has the complaint, am I thinking of an ischemic heart thing, or am I thinking of a reflux? And that needs to be well defined. Glucocorticoid-related complications. All these drugs, no matter how good they sound, have their own problems. They have complications. Then, of course, you have progressive pulmonary fibrosis, which no matter what you do, just goes on and on. At what frequency? We've mentioned this before. Then what other things should we determine as from the BSR, when to escalate or de-escalate therapy? Management questions as posed by the BSR. How should management of the underlying SAR be balanced with the management of ILD? There must be a cooperation between the management of the underlying SARD, because rheumatologists are better at doing that, and then the management of the ILD itself. So there is a back and forth cooperation. So if you have two antagonist specialists, the pulmonologist antagonizes the rheumatologist, you may not get well. You have to work on the same page. How should those with ILD found to have positive autoantibodies without underlying SARD BMI? And we see this a lot. You see patients, and one of the case presentation, patients who just has positive ANA. There's no other clinical feature. How should we manage that? Should we treat him like, for instance, SLE, when the other autoantibodies for SLE are negative? That's some of the things, that's question they need to answer. What are the management in terms of the answers? Glucocorticoids, what dose should we give? What route should we take? Conventional synthetic DMARDs, you have all listed there. Azathioprine has been mentioned, cyclophosphamide has been mentioned. But we also, because this is almost like an exclusive preserve of rheumatology, we're beginning to use biologic DMARDs. We have better experience at using biologic DMARDs, and this biologic DMARD appear to have been made especially for the rheumatology. So the two major ones that are being used, initially it was rituximab. There was a time infliximab was also suggested, but I think currently the only two ones that are being used are rituximab and then more recently tocilizumab. Then there's another group of drugs which had not been mentioned, the Janus kinase inhibitors, which is sitting at the top of the management of all autoimmune disease. And in here we have the various groups, tofacitinib, baricitinib, and upadacitinib. The other aspects of management, IVIG, especially in patients who have idiopathic inflammatory myopathies, very useful in them, especially at certain stage when they develop respiratory distress. And that respiratory distress, you don't know whether it's from the lungs or from the muscles, intercostal muscles. So that goes very well. Antifibrotic therapies, which is the reason why the company sponsoring this meeting. You have nintedanib. But before then, you have pirfenidone, which has been approved only for the idiopathic pulmonary fibrosis. But do you know what? We use it, at least in my own center, we use it since we don't have nintedanib. Proton pump inhibitors, just for all those things. Then what are the others? Lung transplantation. I've had 2 patients who needed lung transplantation. It's not done in Nigeria, and they were billed to travel to the US for the lung transplantation. Unfortunately, it was the COVID period. There were no flights. One of them eventually died from COVID. The other one, I think, died from some other cause. But that's as best as we can, So for us, an early diagnosis, an initial management is more important than waiting until you have lung transplant. Physiotherapy and pulmonary rehab is also a very good thing that we sometimes overlook. physiotherapy do a good job to keeping those lungs functioning. And antimicrobial prophylaxis. Other aspects of management, oxygen therapy we have mentioned, vaccinations, these are also under consideration by the BSR guidelines. Vaccination, what should we vaccinate against? Smoking, everybody has condemned smoking. Nutrition is important. Capillaroscopy was also suggested in terms of especially patients with systemic sclerosis. And then you have a lot of alternative therapies. One thing with medicine, whenever doctors don't have any solution, alternative therapies will spring up, and they are going to compete with you anyway. So you have all this on acupuncture, hypnotherapy, Ayurveda, homeopathy, all sorts, and each one claiming success. Also, they work on personal recognition, and what we say in my country, they work with testimonies. They give testimony as working for them. So if it's working for one person who comes out, the remaining 1,000 who is not working, you're not going to call them to come and say, oh, it's not working for you. So that is the way all these therapies go. Nobody does any control trials. Now, the Korean guidelines was based, it's also by pulmonologists, by rheumatologists, by radiologists. But apparently the voice of the pulmonologist was louder than the rheumatologist. So they started from the premise that I'm facing a patient with ILD. What do I do? So this is what they did. This published in 2016, 2019. And the Korean guidelines for diagnosis and management of interstitial lung, part 5, that means they are dealt with some other parts before finally connective tissue disease came up. And what they say is that, what are the common manifestations? When you see an ILD, why would I suspect connective tissue disease? And they've listed it here, which we can all agree with, renal phenomenon, sclerodactyl, digital ulceration, Gotron's purpose, which is one of the things we see in inflammatory myopathy. Heliotrope rash, we see in dermatomyositis. Photosensitivity, which is almost unique to SLE. Mechanic hands, which we see in inflammatory myopathy. And then joint pains, rheumatologists are specialists of pain, especially in the joints. So anytime you have joint pain. But unfortunately, there usually a delay, because many patients with joint pains end up orthopedic surgeons. And therefore, it takes a long time for them to get through to us. And the orthopedic surgeons, with all due respect to them, all they can do is give NSAIDs. It's not possible to differentiate idiopathic, that's from the Korean guideline. And they say CTD-ILD often manifests as non-specific interstitial pneumonitis. I would prefer to have NSIP than UIP. So anytime we get our radiologists, the question I ask them, please tell me, is it NSIP or UIP? Because I know that if it's NSIP, the prognosis is better. I can therefore deploy my immunosuppressives. I can go to town by using the biologics. But if it's usual, am I likely to achieve much? Now, there's an allusion to surgical lung biopsy. Should we ask for lung biopsy? I think in the Korean guideline, they talk about complications. So they don't really seem to favor it. And they're suggesting that bronchial alveolar lavage may be a possible alternative to lung biopsy. I don't know, maybe our pulmonologist is able to advise us on that, but that's what the Korean guideline is saying. They're also making a very important statement that when a patient is diagnosed with ILD, autoantibody testing should be performed. And I think this might be a take-home lesson for our pulmonologists, that please do the autoantibodies, because you may find out that it may be related to an autoimmune disease. Then what are the sort of autoantibodies they expect? It's all been listed, each one. Antinuclear antibody for SLE, rheumatoid factor, rheumatoid arthritis, SCL70 for systemic sclerosis, RNP for mixed connective tissue disease, SSA for Sjogren's syndrome, anti-CCP for rheumatoid arthritis, ANCA for small vessel vasculitis, JO1 for myositis, and then you have the other ones which are listed. But we also been told that it can present as an acute presentation. When it does, is it that as a superimposed infection, but we should also look at other things like pulmonary embolism. We should look at coronary artery disease and pulmonary edema and pneumothorax. What is initial treatment? Initial treatment is suggesting that we use prednisolone at a very high dose, which is a dose of 0.5 to 1 milligram per kilogram body weight. But then again, once you do that, you are treading on dangerous ground because of the side effect. Many of our patients come back with steroid-induced diabetes mellitus and hypertension, and you now have another set of comorbidity to manage with. So there is the element for us as rheumatologists to use steroid-sparing agents rather than concentrating on steroid. So we look at steroid sparing, and there are quite a lot of them. Virtually all the immunosuppressives have been used. Methotrexate, which had been mentioned, I know there were studies in the past that said that it may not really be implicated in pulmonary pneumonitis, but I think the traditional belief is that it is. So I don't know what the situation is as of now, whether we could still use methotrexate or not. So what are the treatments? We have listed them, cyclophosphamide. Now, rituximab, that's one, have money, you will travel, very expensive. So it's not something that you push onto the patient. We normally will use it in desperate situations. And we must be sure that that patient will benefit from it. So just don't waste the patient's money. Unfortunately, where I come from, most of our patients pay out of pocket. Insurance penetration is quite low. Then you have other things. So the other immunosuppressants are out there. You might want to pick and choose and see which one works, and then move on to another one if it's not working. The prognosis, it varies according to the causative, and this has listed there. And so that's all, but let me just raise a few challenges that we need to conclude my talk. One of the challenges we face is the non-availability and non-affordability of many of these drugs. The second is in terms of, which I made an allusion to, when you, for instance, do the pulse oximeter for a patient with systemic sclerosis and he has a thickened skin, your recording may be, you may not even have it. I've had patients with systemic sclerosis, we couldn't even record their oxygen saturation. And this came about especially during the COVID regime, and they were finding out that the pulse oximeter reading in white was different from that in blacks. And therefore, they were not so sure that they should rely on it to predict COVID. So that's one. The other thing is TB, which an allusion has been made to. Many of our patients could have had TB and have a lot of pulmonary fibrosis. Now, when the condition gets worse, is it the TB that's been reactivated, or could be having something? Nothing stops TB patient from developing any of these other conditions. Then I've mentioned the non-availability of lung transplant. But I think another important aspect, and I direct this to the pharma industries, many of the studies that you do to test drugs don't bother to test Africans. And then you give us a big conclusion and say this works. It may not work, or it may even something that may not work in the Caucasians may actually work in whites. But until the pharma industry includes blacks in their studies, we cannot be so sure. And therefore, this is an area that is a challenge and is something that we need to think about. So on this note, I thank you very much for inviting me.
Kindly let us give another round of applause to the two speakers, please. Those were very exciting talks, Prof. I hope Dr. Zifa is online. Dr. Zifa, we are taking Q&As at the moment. Any questions to the team? Including the online team, please post them on the Q&A section. Yeah. Are there mics?
Thank you so much for that talk. I really identify with a lot of the things that you have highlighted. That is awesome. My question to you is, how much interstitial lung disease do you see in your lupus population?
In the lupus?
Yeah.
I think from our own study, it was less than, I can't remember the figure now, but it's less than 10%. And if you know that most of our patients, or the one that we studied, were actually lupus, the ILD was less than 10%. To answer the question.
Awesome, thank
That's
you.
That's from our reports which had been shown here.
Thank you.
So it appears that our patients with SLE may not be that prone to ILD, or we are missing it. I think it could be either of those two. Okay. But I think it's more that they're not as prone.
Okay, so I think published numbers are less than 5% even. But what type of pathologies do you see?
Type of
So what interstitial lung do you see? Okay. Organizing pneumonia? Do you see UIP? Do you see NC? What do you normally see?
To be honest with you, the issue of categorization into any of this one we leave to the radiologist. For me, as a rheumatologist, all I know, like I mentioned, is NSIP or UIP. Because with those ones, if it's NSIP, I know I can succeed. With the UIP, I know there is nothing I can do. But the other types, to be honest with you, I don't know. But this was reported in our study because the radiologists were the one who reported on it. We don't report on it. Most rheumatologists don't know they are left from the right when you talk about the type. They don't know, honestly speaking. They can fool you by saying they know, but honestly they don't know.
Yes. So, if I may, from our cohorts, I would say that for our lupus patients as well, ILD is far less than 5%. In general, we tend to see the NSIP pattern, and somehow, strangely, a lot of organizing pneumonia in our patients as well. But typically, the NSIP pattern is what we tend to see. But we tend to see in our patients, the ones that are most common is the systemic sclerosis and the idiopathic inflammatory myositis tend to be the ones who tend to present with interstitial lung disease. Not as common in our RA patients as has been alluded to in the literature, but it will be the third disease that we would see in our patient cohort before lupus.
I wanted to say thank you for an excellent presentation. You've covered many of the points in my own talk, so I'm slightly jealous that you've done it so well. But I just wanted to mention the point about NSIP and UIP behaving differently might not be true for all ILDs. In fact, in RA ILD, there's a study of immunosuppression showing that there isn't a difference in response to azathioprine, mycophenolate, or rituximab, whether you've got the UIP pattern or not. Okay. And then, of course, there's a post hoc analysis of the INBUILD study, which had about 90 patients with RA-ILD in there, and they didn't show a difference between the response to antifibrotic therapies, whether you had UIP or NSIP. So, I mean, I agree with you completely. That's always been the teaching, and I also feel much more comfortable seeing a scan with lots of ground glass that's likely to be amenable to immunosuppressive therapy, but I think there are some caveats.
Thank you very much. That's quite gladdening to me, so we can go and use immunosuppressives plus or minus antifibrotic without any fear. I think that's the message I'm taking from you.
I mean, the big question is, what are the shared toxicities? Like you've got someone with scleroderma, you put them on mycophenolate, They've also got scleroderma of their small bowel, and you give them nintedanib. Now you've got multiple reasons for them to have gastrointestinal intolerance. Which drug do you use? Which drug do you stop? I think there's still lots of unanswered questions.
Well, the gastrointestinal is really more with the MMF. So I think when we get that, we just switch to cyclophosphamide. Yes, I think that's what you do, because azathioprine also could be quite challenging in terms of gastrointestinal side effect. I think actually all the immunosuppressants have this issue. So, and then again, another issue with using MMF is pretty expensive. Our patients pay out of pocket. They will tell you we are taking the drug, but they're not taking it. So for us, what we sometimes do, look, let me be sure you're having something by you're coming to the hospital to have the cyclophosphamide, because I know when you default, you have defaulted because your record is not there to show. But that's one of the challenges we face. Patient will tell you, I'm taking the drug because that's what they expect you want to hear. And they're not going to tell you, I'm sorry, I can't afford it. So I think you're right with that.
A question, there are no questions online. So with that, in the interest of time, I will give the whole team 5 minutes to take a cup of tea, and you can bring it along with you so that we can start our next session in the next 5 minutes. For our online viewers, maybe grab a cup of tea too. Thank you. So let's reconvene at 5:20 on top of the hour. 20 past the hour, yes.
She's saying 20 past the hour because of the different time zones. Yeah, is already there. Yours is. Professor, sorry, there was a small technical issue. Wasn't I moved with my phone. I'm running the laptop.
We will start shortly.
So what has happened? So I lost when I lost the. Okay, well, no, not to worry. Connection, but even started running. Okay. Yeah. IT doesn't break down. That's mine. Yes, Emmanuel, thank you. Thank you very much. That's the original. Yeah, I know him. He doesn't Kenya rheumatologist for many years. Me too. That's the original Kenya rheumatologist. Yeah, very first one, yeah. Yeah, the first. I don't know. You don't know him? Yes. Hello. No, this man. I'm Juma. Yes. That's what you from him. Yes. Okay. No, the young ones. One of the first yes. Yes. Yeah, you know. The first man. Oh, really? Cairo. No, we went to Oma. Oh, yes. We went to Cairo to Oma. They were now Professor Harry was just there was a night from here because you know South Africa was so all right, so great. Looking forward to hearing from you. But the North African
Hello?
You must know people.
Okay. Welcome back to all of you. I hope our online viewers are back too. Our next speaker is a speaker from South Africa. So we've done East Africa, we've gone West Africa, now we are back to South Africa. The speaker is Prof. Greg Caligaro from South Africa. He completed his subspecialty training as a pulmonologist in 2012, and he is currently a consultant in the respiratory clinic at Groote Hospital. I hope I've said it correctly. Yeah, Groote? I'll not try that again. Okay. All right. All right, I will know that. I will know that. I'm a research coordinator at the Lung Infection and Immunity Unit. He's working towards a PhD examining the aspect of lung health in patients with HIV infection and on antiretroviral treatment, and as part of an NIH-funded study conducted at the UCT Lung Institute. His research interests include infectious and non-infectious pulmonary complications of HIV. And he is supported by a Discovery Academic Fellowship, an MRC Training Fellowship, and 2 Pulmonology Training Fellowships from the South African Thoracic Society. Prof, you're very welcome.
Okay, thanks very much to the organizers for giving me the opportunity to talk today. And I've been given the topic, which I think has been touched on already several times during this afternoon session, how to identify progression in fibrotic interstitial lung disease. These are my disclosures. So we've spoken a lot about the pathogenesis of interstitial lung disease, and at least the traditional viewpoint was that it started with an injury, okay, of known or of unknown cause, which induced inflammation. And that inflammation led to injury to alveolar epithelial cells. It led to epithelial cell activation, the release of pro-inflammatory cytokines, and the key cell in all of this was the activated fibroblast. It would undergo transformation into a myofibroblast, and that would lead to the laying down of extracellular matrix. It would cause contraction of the lung architecture, and there would be remodeling in terms of disrupting the normal secondary lobules and lung architecture to give us the phenomenon of fibrosis. So I'm just going to minimize this window because I can't see my slides. So if you bear that in mind, you will accept that fibrosis is the common endpoint of many lung diseases of different etiologies. And that's important because if you identify progression of fibrosis, this may have a prognostic significance regardless of the type of ILD. So we're talking about looking at ILD's behavior rather than its diagnosis. Okay, that's fine. Yeah, that's not working. How do I, can I advance with the keys? Okay, all right. So why identify progressive fibrosis? Why is this an important endpoint to have a look at? Well, as our previous speakers have mentioned, I mean, we've just had a discussion about whether the UIP pattern carries the worst prognosis. If you've got fibrotic changes, they are directly predictive of mortality in a variety of interstitial lung diseases. Obviously in IPF, but also in RA-ILD, as we've heard, scleroderma-associated ILD, fibrotic hypersensitivity pneumonitis, sarcoidosis, and even in the basket case group of unidentified ILDs, which haven't yet been classified as their workups have been incomplete. As well as that, a sizable proportion of patients with fibrotic changes will progress. And so we often detect these early interstitial changes on CTs done for other reasons, maybe for investigation for lung cancer, CT pulmonary angiograms. They're also often appreciated on the lower lung slices of abdominal CT scans. And what we see are fine reticulation, intralobular lines, and architectural distortion with some intralobar volume loss. And these abnormalities are called interstitial lung abnormalities, or ILAs, because they're occurring in asymptomatic patients. But if you follow these people up, about 40% of them will progress. So using the model of inflammation leading to fibrosis, we can see that there's a spectrum of interstitial lung diseases where inflammation is more prominent in some and fibrosis is more prominent in others. On the far left-hand side of this graph, you've got organizing pneumonia, which is an inflammatory disorder with buds of granulation tissue in the alveolus. And of course, it's one of the most gratifying conditions for respiratory physicians to treat because it melts away with the use of anti-inflammatory treatment. On the opposite side, we have idiopathic pulmonary fibrosis, where there isn't any evidence of inflammation. And if you do a lung biopsy, you find different foci that are temporarily distinct. In other words, there's heterogeneity in the time that these lesions started without finding any inflammation. And we know that they don't respond to anti-inflammatory therapy at all. And so we're left with this Venn diagram where you've got idiopathic pulmonary fibrosis in the middle, and the other interstitial lung diseases and idiopathic interstitial pneumonias, which intersect at varying degrees with the central circle of pulmonary fibrosis, and so demonstrate different prevalences of pulmonary fibrosis in their radiological presentation. So we've seen this graph classify, or this table classifying ILDs other than IPF several times today. But what this graph shows is the estimated proportion of patients shaded in blue who manifest pulmonary fibrosis. Now, these are not always epidemiological studies. Most of this is based on expert opinion, but it backs up a lot of the data that we've heard in previous talks. For example, in rheumatoid arthritis, about 50% of patients will have pulmonary fibrosis, usually of the UIP pattern. In scleroderma, although NSIP predominates, there's also a high proportion of patients with pulmonary fibrosis. Whereas in the idiopathic myositis or in Sjogren's syndrome, that percentage is much lower. So you can see that the type of lung disease will determine what the prevalence of pulmonary fibrosis is. So again, why define progressive fibrosis in ILD? Well, up until now, we've been fixated in talking about lung diseases by their underlying diagnosis. This patient's got scleroderma. We're going to treat them with cyclophosphamide. This patient's got rheumatoid arthritis. Anti-inflammatories are unlikely to help. We're going to use an antifibrotic. But we need to move away from looking at the diagnosis and rather ask ourselves, how is the ILD behaving? Is it progressive or non-progressive? Is there a decline in the FVC and the DLCO? Is there worsening radiological progression? Because ultimately, these are the patients that we want to treat. We don't want to expose patients with stable disease to all the complications of antifibrotic drugs or particularly of immunosuppression and glucocorticoids. We want to identify patients at most risk of progression. So what's in the name progressive pulmonary fibrosis, which we've heard about a lot today? Well, this was previously referred to as a progressive fibrosing interstitial lung disease. But as we've heard, calling this an interstitial lung disease is probably an underrepresentation because we have disease progression that extends past the interstitial lungs, interstitial space into the parenchyma. It involves the airways with traction bronchiectasis and traction bronchiectasis, and it may also involve the vasculature. Secondly, calling this progressive pulmonary fibrosis reminds us that these patients behave very similar to IPF, with a clinical course that is rapidly progressive and could lead to respiratory failure within 3 to 5 years. And lastly, the term PPF is simple and compatible with the broadly used term that clinicians and patients understand, which is pulmonary fibrosis. Again, I will just remind you that PPF is a behavior, it's not a diagnosis. And we should consider it in any patient with ILD of whatever etiology, known or unknown, who has radiological evidence of pulmonary fibrosis and has at least 2 of the following 3 criteria occurring within the last 12 calendar months: worsening respiratory symptoms and worsening restrictive physiology, or worsening diffusing capacity, and I don't know why it didn't fit in my red block, radiological evidence of disease progression. So let's unpack those 3 criteria. Well, firstly, worsening respiratory symptoms is easy to understand. Cough and dyspnea are the cardinal symptoms of ILD, and all of our patients complain more of these as their disease progresses. In fact, increased cough and MRC dyspnea score are independently associated with worse prognosis in interstitial lung disease. So here, symptoms are a very good surrogate for whether patients are getting worse or not. Of course, if you're looking at somebody who's more symptomatic, there are some important caveats in that you have to exclude alternative causes. You have to exclude intercurrent infection. Depending on what anti-rheumatic drug the patient is on, you may need to exclude a drug-induced lung disease. Causes of worsening lung function and symptoms could be heart failure or fluid overload. Patients often have multiple comorbidities. This could be an acute exacerbation of the interstitial lung disease, or in the case of patients who also have concomitant emphysema, an exacerbation of an alternate lung disease. And then lastly, the manifestations both in diffusing capacity and in symptoms may be related to anemia. There are also some clinical criteria that we all recognize that indicate worsening, but are more variable and which don't form part of the definition of PPF. Worsening 6-minute walk test, okay, with all the caveats that we've heard from our previous speaker in rheumatic diseases and how that might be unreliable. The development of pulmonary hypertension, which is something that we may pick up clinically or on echocardiogram. The presence of an acute exacerbation, which we know is associated with worse prognosis, but doesn't form part of the PPF definition. Increased hospitalizations, and then patient-related worsening quality of life, which is not something that is assessed in this assessment.
This meeting is being recorded.
The speaker that follows me, who's going to talk on antifibrotic therapy, will probably discuss the INBUILD trial in great detail. But you can see here how FVC decline over 52 weeks was an important endpoint. In fact, it was chosen as the primary endpoint. And you can see how patients on placebo with both a UIP and a non-UIP pattern progressed over that period. So it's associated with progressive symptoms, with increased healthcare utilization, and ultimately with mortality. So what does it look like identifying somebody with PPF? Well, this is a patient from my clinic, a 61-year-old woman who's got a background of rheumatoid arthritis on methotrexate. We've got serial x-rays to show that her lung function and x-rays did not deteriorate after commencement of methotrexate. This is something that's happened many years later. She's got no other occupational or domestic exposures, and her physical exam reveals classic digital clubbing and, of course, the fine Velcro crackles of interstitial lung disease bibasally. Her X-ray shows bilateral infiltrates, reticular nodular, increased cardiac shadow with indistinct left cardiac border, and a reduction in lung volumes. Her HRCT, unfortunately, I can only play this quite quickly, so I'll play it a few times, but it shows marked reticulation and areas of ground glass in the areas of reticulation. I can't seem to show that again, but it is a marked apicobasal gradient with an absence of honeycombing. So this fits the non-specific interstitial pneumonia pattern. Her lung function shows a vital capacity of 50% predicted. So that's a moderate decline in functional capacity. And her DLCO is 40% of predicted. So that's a moderate to severe reduction in diffusing capacity. She's got mild pulmonary hypertension on echocardiography, and she's got no GORD symptoms, but she is on a PPI. This is what our lung function chart looks like that we record on all our interstitial lung disease patients at the clinic. And you can see that after an initial decline in the year 2018, there was a long period of stability where she was maintained on prednisone and azathioprine. And the red block with the dotted lines that I've indicated is really once her clinical progression started to deteriorate and when we started getting worried about other treatments. So I've zoomed in on it on this graph, and you can see that from a baseline FVC of about 68% predicted, she declined in 10 months to an FVC of 59% predicted. So that's an absolute reduction in FVC of 9% predicted. So the diagnosis of PPF does not rely on a relative reduction in FVC. It's an absolute reduction. And you can see that this patient deteriorated further with another 14% in the next 6 months. So clearly on a downward clinical and radiological trajectory. The guidelines also talk about identifying PPF by looking at the measurement of diffusing capacity. But here the limit is much more generous. Instead of saying 5%, they say more than 10% within a year of follow-up. And they give the caveat that the DLCO is a much less robust measure than FVC, and we must exclude alternative causes of worsening diffusing capacity. Now, there are some problems with DLCO as a reliable indicator of deterioration. Firstly, I think there's an issue of access. And we only have diffusing capacity available at our major academic hospitals, so regional or provincial hospitals usually only have spirometry, so it's not always available for testing. Secondly, DLCO shows significant measurement variability between patients, and also there are different techniques between the different labs on how it gets measured. And then lastly, it lacks specificity for pulmonary fibrosis. It may be reduced because of anemia, because of respiratory muscle weakness, because of concomitant cardiac failure. So there are many reasons why the DLCO might be reduced that aren't specifically relevant to the diagnosis of PPF. Having said that, if you look at clinical trials, a decline in DLCO once all those other diagnoses have been excluded is a strong predictor for mortality in a variety of fibrotic lung diseases, and that's the reason it was included in the guidelines. Radiological progression of disease activity is usually assessed visually. We had some questions earlier on AI and possibly on quantitative CT measurements. And this is something that's been expressed as an area of interest, but hasn't been included in the guidelines. And they still recommend a visual assessment of progression, relying on determining the percentage of lung volume containing fibrotic features in the upper, middle, and lower zones. And they do comment, and I'm sure those of you who look at HRCTs often will agree, that it's sometimes easier to look at it in the sagittal and the coronal sections than it is to look at it axially to determine whether there's progression. So what are the features on HRCT that show progression? Well, increased extent or severity of traction bronchiectasis and bronchiectasis. New ground glass opacities, okay, but obviously they've got to occur within areas of known fibrosis, so they've got to happen within areas of traction bronchiectasis or bronchiectasis. Remember that ground glass occurring outside of areas of fibrosis might be due to an alveolitis. New fine reticulation, increased extent or increased coarseness of the reticular abnormality, and I'll show you an example of that in a second. Of course, new or increased honeycombing. I mean, that's a very clear sign of progression. And then lastly, increased lobar volume loss. Okay, so evidence of architectural destruction and of shrinking of the lung volumes. So this is why I said it's sometimes easier to look at it in this projection. So this is the same patient that I showed you earlier. This is her CT on the left done at time point A, around the time of her diagnosis. And this is a CT done, it's about 3 years later, so there are some interval scans in between, but I'm obviously showing you ones for maximum effect. And you can see here that there's been a marked reduction in lung volumes, and there's been an increase in the intensity of the reticular abnormalities. And if you look at the bases, you can see how there's been traction bronchiectasis and bronchiectasis with surrounding reticular abnormalities. So clear evidence of progression on the coronal section, and even more visible on the sagittal section, where we see the very dilated airways in the bases, also in the lung apex. A previous speaker spoke about the sensitivity of finding reticular changes or fibrotic changes in the anterior aspects of the upper lobes as being suggestive of connective tissue disease associated ILD. And I think this demonstrates it quite nicely. You can see how the anterior aspects of the upper lobes are affected. So we are going to be talking about the INBUILD study, which of course is the pivotal study of antifibrotic therapies in the treatment of PPF. But I think we should just point out that there are a few differences in the entry criteria of patients in the INBUILD study compared to these new PPF guidelines. So the first one is that I showed you that in the guidelines, we talk about an absolute decline in FVC of more than 5%. Whereas in the INBUILD study, they used a relative decline in FVC of greater than 10%. So working out the relative decline involves taking the second FVC, minusing it from the original FVC, and then dividing it by the original one. So you're getting a percentage decline. That's a relative decline. Secondly, INBUILD criteria only needed one or more measures of symptoms, radiological progression, or physiological progression over 2 years. Whereas, as I've told you, the PPF guidelines require 2 out of 3, and it's in 1 year. And then lastly, the INBUILD criteria don't provide specific guidance on radiological progression. Okay, whereas in the PPF guidelines, they give clear measures as to what you should look for in defining radiological progression: the fine reticulation, the increased ground glass in the areas of traction bronchiectasis, the more increased honeycombing, etc. So if I could sum up, I would say that identifying fibrotic ILD is important, and identifying progression is important because it may have more prognostic significance than the actual underlying diagnosis. Okay, and identifying patients whose prognosis is progressing is important because we'll be able to talk to them about what their clinical trajectory is likely to be, and there's going to be a whole lot of advanced planning that's going to happen with that. And lastly, and I'm not going to talk much about this because I'm sure it's going to be covered in the second talk, because treatment with antifibrotic therapy, and in particular nintedanib, reduces this FVC decline. Okay, thanks for your attention, and I'll take any questions in the Q&A session later. Okay. No, that's the top. No, it's not that one. It's the top one. There we go. Implementing guidelines. It's that one over there. it from the start. And I just want the presenter view. I can have the presenter view. No, hang on, where's the presenter view? I can't see it. No, I want to see the presenter view. See, where's the presenter view here? Yeah. I don't know what's underneath there. What's underneath there? Close it there. Yeah, okay. Okay, just go, it doesn't matter, it's fine. Okay. All right, so my second talk is called Implementing Guidelines for Patient-Centered Care in Interstitial Lung Disease. And I think also a lot of this topic has been covered by previous speakers, because we've spoken about guidelines and we've spoken about the deficiencies in the African setting and why they might not be completely applicable to our resource-limited environment. These are my disclosures. So I'd like to say that I think this is a very aspirational talk. Okay, we want to know what's the best way we can implement the best guidelines and really establish patient care in the best way possible. And I think this means using guidelines that come from an excellent evidence base. And I think that it means using therapies that are easily available. It means having a big multidisciplinary team involving nurse practitioners, radiologists, physiotherapists, access to pulmonary rehab, access to lung transplantation. And I think, like this unicorn, it's probably a mythical endpoint that we're unlikely to be able to reach. And I have to say that in my practice, it's more like this old horse, where we're doing our best with resource limitations, and we might not have all the access to the therapies that we would like. Access to investigative strategies has also got long time lags. But we're still trying to, and we know that our guidelines are based on information that doesn't cover all of our diagnoses. So I think to talk about implementing guidelines in a way that is perfect for patient-centered care is a noble concept, but unlikely to really be happening in practice. So this is the outline of my talk. Okay, we've spoken about the difference between guidelines and consensus statements and position statements. But what level of evidence should our guidelines ideally be based on? And I think I did mention earlier, other than for scleroderma and for IPF, there really is a dearth of good quality data, randomized controlled, double-blinded data for the majority of the interstitial lung diseases. And I'll show you a cartoon later on that shows what we really know about the interstitial lung diseases. The next question, and this is going to cover some ground that was covered by a previous speaker, is, well, what do we know? What are the key practice-changing clinical trials in interstitial lung disease? I'm going to briefly touch on a few new RCTs that I think haven't made any guidelines yet, but are important to know about, and we are likely to see influence guidelines. I'm going to talk about why we have some problems with interpreting clinical trials in ILD, both because of their generalizability to our setting, but also because of the different trial designs that make it a bit difficult to know which treatments to implement in different patients. Then I'm going to just look at what knowledge do we have, what do we know, and what are the limitations. And then lastly, talk about patient-centered care and ask the question, how can we implement this in interstitial lung disease? So as I've said more than once, the results of key clinical trials that have informed the development of guidelines for ILD have come largely out of the IPF and the scleroderma space. So the very first big RCT in interstitial lung disease was the Scleroderma 1 study, which comes from 2006. And this showed that cyclophosphamide was better than placebo at reducing FVC decline in scleroderma-related lung disease. Following on a few years later, we had the Capacity and the Ascend trials, which looked at the antifibrotic pirfenidone in IPF. And of course, those were landmark studies. And then, as we've heard, The 2012 publication of the PANTHER study, which showed that the use of N-acetylcysteine, azathioprine, and corticosteroids not only didn't work, but was actually harmful. This was a paradigm-shifting study and led to the guidelines being published saying that no patient with IPF should actually be given treatment, but should be enrolled in a clinical trial. Then we had the IMPULSIS study, which looked at nintedanib in IPF. And based on all of this work, the first ATS, ERS, GRS, ALAT guideline for the treatment of IPF was drawn up. The next big sentinel study was the Scleroderma Lung Study 2, which compared mycophenolate with cyclophosphamide in the treatment of scleroderma-associated ILD, and showed that they were equally effective, but with a much lower side effect profile with mycophenolate, and that's made mycophenolate, certainly in our setting, the standard of care, as long as there's no contraindication and patients tolerate it. Then the other two big trials that we've had is the SENSOR study, which is looking at antifibrotic therapy and scleroderma. And then, of course, and it will be discussed just now, I think, is the NBUILD study, which is the only study to look at ILDs other than scleroderma and IPF. And this looked at, obviously, a basket case inclusion criteria of any form of progressive pulmonary fibrosis, and we've already covered that in the previous talk. Here are a couple of new RCTs, which I think are going to be practice changing. Okay, this is called the TRAIL-1 study. It's a study looking at the efficacy of pirfenidone in patients with rheumatoid arthritis-associated ILD. The speaker from Nigeria, I think, mentioned that he's already using pirfenidone for this indication because of the absence of nintedanib. And here's data backing up that practice. Pirfenidone does reduce the decline in FVC and RA-ILD by about 50%. So that's very similar to what we've seen with nintedanib in a post-hoc analysis of the NBUILD study. So it seems that antifibrotic therapies work in RA-ILD irrespective of whether it's pirfenidone or nintedanib. This, I think, is a very important study for me. This is called the RECITAL study. And here, physicians were asked to enroll patients who they thought had rapidly progressive interstitial lung disease. And the patients that they enrolled were those with scleroderma, those with the idiopathic inflammatory myopathies, and those with mixed connective tissue disease. So there were no lung function criteria. There was no definition of progressive pulmonary fibrosis. There was no mention of what previous therapies the patient had to be on. If the clinician was faced with a patient that he thought was rapidly deteriorating, and he would otherwise have given them cyclophosphamide, and I think most of us who practice in the ILD space will automatically reach for cyclophosphamide in a patient that we see is rapidly deteriorating, they randomized them to either rituximab or cyclophosphamide. And this showed that rituximab was as effective in cyclophosphamide, but with a much better side effect profile. And I think and this doesn't apply to my setting, but in settings where there's access to rituximab, we may want to use this over cyclophosphamide in patients with rapidly progressive ILD. Of course, in terms of compliance, it does have the benefit of only 2 infusions 2 weeks apart, as opposed to monthly infusions for 6 months. This study looked at non-specific interstitial pneumonia as a group. Okay, in this group, the majority of patients had connective tissue disease-associated ILD. So the sizable proportion of patients had connective tissue disease-associated ILD, and they randomized them to either mycophenolate alone or rituximab as induction therapy plus mycophenolate. Now, I'm just mentioning that this includes patients with idiopathic NSIP, IPAF, and those with connective tissue disease-associated ILD. So again, a bit of a basket case of entry criteria. But they showed that rituximab and MMF was superior to MMF alone. So this is something we may also want to bring to our practice. And then lastly, and it's quite interesting because this has been presented at the ACR meeting in November 2022, but hasn't yet been published. This is the results of the Scleroderma Lung Study 3. Okay, so this was a study that compared mycophenolate, which, as I said, is the standard of care, to pirfenidone plus mycophenolate in patients with scleroderma. Now, we know that the other antifibrotic nintedanib in the SENSOR study works in scleroderma, but here this was a negative study. Over the 18-month study period, they showed a similar improvement in FVC in the 2 arms, and the only positive finding was that Patients' FVC improved a little bit faster in the first 6 months if patients were on pirfenidone, but that difference eventually smoothed out by 18 months. So why do I say that there's a difficulty in interpreting clinical trials? Well, there's a large heterogeneity in the entry criteria for patients who are enrolled in trials of connective tissue disease-associated ILD. I told you about the recital. The recital study was the one where patients with rapidly progressive disease were enrolled. So here, the entry criteria was the physician decision to treat. There were no objective criteria. It was just whether, in the opinion of the treating physician, this patient was rapidly deteriorating. Then we've got studies that only look at the underlying diagnosis. Scleroderma lung study 1 and 2 didn't rely on patients that were showing evidence of radiological progression. The census study just enrolled patients with scleroderma indiscriminately. The EVER-ILD, so the study of rituximab versus mycophenolate and rituximab in NSRP, just needed the diagnosis of NSRP. Excuse me, and the TRAIL-1 study, which was pirfenidone and RA-ILD, enrolled all patients with RA-ILD, irrespective of whether they were deteriorating or not. And then you've got studies that only enroll patients depending on how their ILD behaves. So the INBUILD study, which looks at a fibrosing phenotype or a behavior of the FVC. So I did say that there was a paucity of guidelines, and this is that same table that I showed you earlier, and that's been seen several times today. But highlighted in yellow and in blue are the only real guidelines that are available. So some on autoimmune interstitial lung diseases. Obviously, I'm excluding guidelines on IPF because these are ILDs other than IPF. There are guidelines on scleroderma, and our previous speaker spoke about the British Society of Rheumatology guidelines. The EULAR recommendations for the treatment of SSC. There's a European expert consensus statement on the diagnosis and management of scleroderma-associated ILD, and then there's the Japanese guidelines. Other interstitial lung diseases that we've got guidelines for are diagnosis of hypersensitivity pneumonitis, but not treatment of hypersensitivity pneumonitis, guidelines on LAM, and some guidelines on sarcoidosis. But you'll see that the majority of these squares are white, showing that we've got no official guidance from our international bodies on how they should be treated. This, of course, is an important document. So as I said, IPF and PPF are well represented in the guidelines, and this is a guideline published in the American Journal of Respiratory and Critical Care Medicine in 2022. And in terms of my own practice, these are the current guidelines that I feel are in widespread use. So the IPF guidelines I've already shown you, the sarcoidosis guidelines and the ERS clinical practice guidelines on the treatment of sarcoidosis I refer to. Lymphangiomyomatosis is such a rare disease, it's not often something that we have to look up. The diagnosis of hypersensitivity pneumonitis, and then a new document, the ACR guideline for the treatment of ILD in patients with systemic autoimmune rheumatic disease, and that comes from 2023. But again, although this gives 36 treatment recommendations for first-line ILD treatment, treatment for ILD progression despite first-line treatment, and treatment of rapidly progressive ILD, I mean, it's been released as a summary document, and I think it's fairly impressive. It's a consensus document, so it's not a high quality, there hasn't been the grading of evidence or of recommendations, and it's just a consensus document from the American College of Rheumatology. As I said, there's been some consensus statements from European and American College of Radiology on advocating MMF, cyclophosphamide, and nintedanib with scleroderma. I mean, I think that we've got good, excellent randomized controlled data to support. I've spoken about how the guidelines on the diagnosis of hypersensitivity pneumonitis, but again, nothing to inform treatment. And I think that all of these guidelines have limitations, and I think the previous speaker alluded to these very well. The evidence on which these guidelines are based is informed by ILD patients in the global north. We don't know whether genetic and exposure differences in our populations will mean that they would respond differently to treatment. We know that the epidemiology of ILD differs across the world, and that is, of course, because of differences in occupational, domestic, and exposures. Also, I think, and I was told earlier that maybe South Africa is a different kettle of fish, but I think we've got the similar resource constraints to the rest of Africa. but the current guidelines recommend care that may not be feasible on a global scale. And in my own practice, I'm thinking about access to HRCT, outside of academic centers, access to lung function, even spirometry, access to thoracic surgery for lung biopsies. In rural areas, we have problems with supplemental oxygen, and also the feasibility of getting an MDT discussion on every patient with ILD. I mean, these obviously happen in academic centers, but how many patients with ILD are being managed at regional hospitals and are falling through the cracks? And then lastly, and again, as I said, my thunder was stolen because this was mentioned, we need to exclude current or prior TB infection as a cause of radiological abnormalities. So we've got a lot of smoke that's clouding our radiological presentations of ILD, and that's often because of the previous TB and high burden settings. So moving on to the second part of the title of my talk. So what is patient-centered care, and how can we apply this in ILD? Well, patient-centered care is a healthcare approach that respects and responds to the preferences, the needs, and the values of patients. It prioritizes the patient's individual experience, and I've heard this from previous speakers. It's not good enough to tell someone that their lung function is stable when they tell you that they're feeling worse and that their cough is worse. We have to involve them as active participants in their own care, and we have to have shared decision-making. And patient-centered care is aimed not only at improving the physiology of a patient, but improving the quality of the healthcare that is given to the patient as a global whole, and enhancing patient satisfaction. Now, clearly, those are very noble aims and not always easy to implement. But what are the deficiencies in patient-centered care in interstitial lung disease? Well, in a survey of almost 1,500 patients with pulmonary fibrosis, over 2/3, and obviously this is in the global north, this is not African data, 2/3 reported that they were given a lack of information on their diagnosis, and they also weren't told about the resources that they could access on pulmonary fibrosis at the time of diagnosis. Fewer than half felt well informed about treatment options. They didn't know about the role of supplemental oxygen. They didn't know about pulmonary rehabilitation. In centers where it was available, lung transplantation wasn't offered. Many patients also think that psychological support is lacking in interstitial lung disease. And then lastly, most patients, and I think this is obviously a deficiency in the form of the clinician who wants to always be hopeful with patients who've got diseases that have got that have got bad prognoses. Palliative care is not discussed early enough in the patient's journey. So how do we talk about patient-centered care in interstitial lung disease? Well, Jackie in our very first talk spoke about the village that it takes to look after someone with ILD. I mean, the question is, do you always have everybody in the village? They talk about the importance of an MDT, using an ILD nurse, an ILD practitioner, a physiotherapist, a pharmacist, a respiratory therapist, a social worker, a psychologist. But are all of these different members of the team attainable in the local setting due to resource constraints? And this diagram on the right just shows how an interlocking chain of all of these allied medical disciplines are necessary to provide real patient-centered care in ILD. So again, let's look at the unicorn. What is the gold standard? What is our mythical aspirational model for the treatment of ILD? Well, people have spoken about the ABCDE model of patient-centered care in interstitial lung disease. And the ABCDE stands for assess, backing, comfort care and comorbidities, disease-modifying treatment, and end-of-life care. And I'm going to just quickly go through these, and some of them are, as I say, difficult in our setting, but some just with some insight and with some awareness we can apply to our own clinical practice. So in assess, we have to individualize the patient's ILD journey. We have to assess their needs and values. We have to, if we can, involve their partners, involve them as partners in care with shared decision-making. And that often means including caregivers at a very early stage. The next, which is backing, is we have to back them with education. If possible, we may be able to teach them about self-management of symptoms like cough. We will point them in the direction of support groups, which may be patient-driven, patient advocacy groups that motivate for increased care for them. I mean, I'm sure you all know that when it comes to hospital administrators, They listen much better to patients than they do to doctors. They can be referred to pulmonary rehabilitation. It can be prevention, so stopping smoking and vaccination. And lastly, if these are available, you may discuss referring them to clinical trials where it's possible they may have therapies that may prolong their lives. In terms of comorbidities, we have to really focus on comfort care from an early stage, treatment of dyspnea, treatment of cough. These are the symptoms that really impact patients' quality of life. Fatigue, depression and anxiety. It's estimated that about 60% of patients with ILD suffer from depression and anxiety. And we have to introduce other palliative options early, understanding that palliative care is not something that refers only to end-of-life care, but is a system of care that's devoted towards symptom management at every step of the treatment process. We also want to address comorbidities, cardiovascular comorbidities, obstructive sleep apnea if it exists. Patients with pulmonary fibrosis are obviously predisposed to developing lung cancer, both because of shared risk factors like smoking, but also because of scar carcinoma. We might be able to treat airways disease that might improve the condition as well as treating reflux. And then we'd want to move on to disease-modifying treatments where available, antifibrotic drugs, immunomodulatory therapies if applicable, and lung transplantation if a patient is eligible and it is offered in your center. And lastly, and I think very importantly, I mean, the IPF guidelines say that at the time of diagnosis, somebody with IPF should be referred to two things. One is lung transplantation if available, and the second thing is palliative care. And I think that I speak for myself when I say that I involve our palliative care colleagues much too late in this process, because we want to time the discussion that their symptoms are managed by another team early. You want to discuss the fears around dying, their practical needs about how where they would like to die, what the palliative options are, preferred place of dying, preferred way of dying, and also to be honest about our treatment limitations, about resuscitation, about ventilatory support, and allow the institution of a living will or a DNR so that these patients aren't subjected to undignified end-of-life care. Lastly, just to say, and I won't go through this whole slide because it's obviously quite busy, but patient-centered care involves measuring patient satisfaction. And there's a whole lot of different scales which are secondary endpoints. And just to specify that the recital study excluded patients with RA-ILD, I'm going to try and use rituximab plus mycophenolate for the NSIP pattern in connective tissue disease-associated ILD. And then we've shown that with the scleroderma lung study 3, that pirfenidone isn't the antifibrotic of choice in scleroderma-associated ILD. Then when it comes to patient satisfaction and patient-centered outcomes, it's important that we include patient-reported outcome measures as endpoints in clinical trials, and maybe we should be incorporating them in our daily practice. And lastly, guidelines must include holistic patient journey with special emphasis on education, shared decision-making, and early palliative care. Thank you for your attention, and I'll take some questions in the session. Thanks.
I think Prof deserves a better round of applause. That was awesome. Thank you so much for making the trip. It was worth it. I will call in the last speaker, then we can have a Q&A. Allow me to introduce Dr. George Nyale. He is the head of respiratory unit at the Kenyatta National Hospital, which is our leading tertiary hospital in Kenya. He is also the past president of the Respiratory Society of Kenya. Past. Former, okay. He prefers.
This meeting is being recorded.
PPFs. They only come to us when they have symptoms. I'm yet to see a cohort that starts with normal people and then looks at them over 30 years to see, or 50 years to see how many develop fibrosis and to look at the risk factors. So all what we have, the risk factors, those are theories. And you see, when we are looking at theories, there are those who believe that IPF, or usual interstitial pneumonia, is actually the final lesion. That all these things, finally, when you get very fibrosed and there's so much damage, they almost look the same, while others believe it's a different lesion. How many believe it's the final common pathway? IPF. Okay, 1, 2, 3. The others believe it's a different disease, yeah? So, well, for those who believe about disease diagnosis, you're right. But if you look at behavior, which is now more important, people are looking at behavior of these pulmonary fibrosing diseases, they look the same. Because if you start with IPF or you start with any other disease, towards the end, the behavior is the same. The second question, yeah, are symptoms of progressive PPFs, are they any different from IPF? Anybody who has a different symptom of progressive IPF and progressive PPF, I think that things are the same. Worsening cough, worsening shortness of breath, developing other comorbidities, yeah? So they almost look the same. And then the complications of IPF and PPF, are they any different? So might we be splitting hairs just to ask ourselves, do we need to differentiate, especially when you're looking at behavior of the ILD? Then the other question, I think this was answered by, I think the second speaker, Prof. Buika, who answered, what is the most important target when we are treating? Is it mortality? Because we say this disease is progressive. Okay? Is that our most important thing? Because you said most people don't want to die, but it's obvious all of us will die, whether we'll be hit by a trailer or we'll die of IPF. We don't know which will come earlier. And then there's the issue about respiratory related mortality. Okay, is that an important thing to us? That if you have somebody with IPF but he dies of an accident, you are happier? Or is death just death? What are acute exacerbations? Prof just touched on it. Is it an important endpoint for you? If these patients are being admitted all the time, and if you can get a drug that can stop them coming from the hospital. Progressive symptomatology, whether clinical, and that's the one that's quite important, 6-minute walk test, the respiratory questionnaires, if you can score cough, and if cough is disturbing to them, or you want to do tests like declining lung function, where VC is the most common, although you can use DLCO, okay? Or is it the side effects of therapy? By the way, which is most important to you if you are to choose one here? How many say mortality? Okay, Prof. Buika. How many say acute exacerbations? Nobody. How many say progressive symptomatology? Biggest, sizable 4. How many say declining lung function or stability of lung function? Nobody. How many say side effects of treatment? Wow. So most of you actually are interested more in the symptomatology. So there's a bit of consensus there. And obviously, side effects. And then finally, I always ask myself, what are guidelines for? Okay. Because what we are seeing now coming from Europe, sometimes there are consensus statements, and I'm sure Prof has touched about it. So I'll try and stay on the guidelines or consensus statement and avoid experimental treatment in this talk so that all of us are in the same thing. So generally, because we have a consensus, and at least there's better consensus on treating IPF than PPFs, I decided to start from that point. Okay? So I asked myself, if I changed diagnosis there from IPF to PPF, okay, what consensus do we have here? I'm sure on the non-pharmacological, all of us have consensus. How many agree when in PF patients should be given oxygen? By a show of hands, only 2. Okay, almost everyone. How many believe PPF patients should go to pulmonary rehab? We agree on that. How many believe we should look for comorbidities in PPF, pulmonary hypertension, gastroesophageal reflux, sleep apnea, or lung cancer? So all of us agree. And symptom control is very important. So all of us agree on that one. So we don't need to discuss that one because all of us are in agreement. Is that okay to say? We also have a big consensus on monitoring this progressive pulmonary fibrosis. All of you agree, 6-minute walk distance is important. If they can walk, that is if they don't have rheumatoid arthritis in the hip. Is that clear? All of us agree. So there's consensus there. We all agree that HRCTs can be used to monitor progression, okay? Whether it's annually or whenever they have an exacerbation, and obviously lung function, okay? And that acute exacerbations are important for us to see, and especially to see if we can have any role for anti-inflammatories, including corticosteroids. So because those ones, I think we have consensus, I shall not talk about them. Do we have an agreement? So study, and 64 on pirfenidone, 63 on placebo. And what they showed was that there was a tendency to a slower decline in FVC in the patients given pirfenidone as compared to placebo. And in absolute terms, the rate of decline was about 1.69% less in the pirfenidone group. This reached statistical significance. But remember, it was not the original idea to only analyze 127. It was to analyze a whole group of 324 patients. So how do you interpret data in such a small number? That becomes another issue that you have to look at. When they also reported deaths for those who are looking at mortality, and they said there was one death in pirfenidone group, okay, which is 2%, but it was non-respiratory related. They didn't exactly give details of what it was. And in the placebo group, there were 5 people who died, yeah? And 3 of them were respiratory related. And then they went ahead to tell us the side effects and infections and infestations. 5 cases in the pirfenidone group and 10 in the placebo, okay? And then there were quite a number of other generalized side adverse effects, including disease worsening, cardiac, okay? And basically, they tended to show that in the pirfenidone, it was not so much worse than in the placebo group. But remember, these were in minute numbers. So in conclusion, I want you, and that's why I've put there the word caution. You have to take plenty of caution when you're reading these results. But they concluded that adding pirfenidone to an existing treatment regimen can attenuate disease progression as measured by decline in FVC. But take caution, because they never enrolled the number that they were supposed to enroll. And I wonder why they were even allowed to analyze that data and actually publish it. Okay, the second trial basically gave pirfenidone to patients who had unclassified progressive fibrosing pulmonary fibrosis. And this was a hodgepodge of diseases. And this one now was extended to whole of Europe. So it was a phase 2 trial in 70 centers across Europe. And the eligibility here, they pushed it a little bit, yeah, to 85. I'm hearing the Swedish and the Danish live longer. So they pushed it now to 85 instead of 80. And basically, they also stratified according to what kind of medication were you on, like mycophenolate, and what kind of disease did you have? Did you have an interstitial kind of pneumonia with autoimmune features or not? And the primary endpoint, again, was the change in the absolute FVC at 24 weeks, which is a bit short because it's really 6 months only, okay? And this, I think, was informed because the other study earlier there's a study that has shown after 6 months of pirfenidone, the increase in FVC sort of leveled out, which again brought the question, why did they lower the time? So when you are reading this again, you need to know that there are studies that have shown when you use pirfenidone in such diseases, after the first 6 months, the difference in FVC sort of flattens out. So one wonders why they made it shorter instead of the 1 year length of follow-up that is required. The most important thing here they said was that they were going to measure it by daily home spirometry, okay? Which is not really a standardized measure, and you really can't control for the errors that the patient does, okay? But anyway, that was their primary endpoint. And what basically they found out, they actually enrolled the number that was required to 53, 127 in pirfenidone, 126 in placebo. But they had a very interesting thing. The mean change in FVC measured by home spirometry was not statistically significant, although the one measured at the trial center using the trial spirometry was significant. Now the question arose, is it because the patients were not able to do home spirometry as well, or what was the problem? Okay. They also gave us other treatment emergent side effects, which basically showed slight more side effects in the pirfenidone arm as opposed to the placebo. And I've given you some of them, like the gastrointestinal, the fatigue, and obviously the rash associated with the pirfenidone. So what they included here is that although they did not achieve what was planned out in the primary endpoint, which was to analyze the FVC change on the home spirometry, although that was negative. It was not achieved. But their secondary endpoint suggests that adding pirfenidone to unclassified ILD can benefit. And basically what they recommended was more studies, and they recommend that it should be longer, and probably we should have a standardized spirometry as opposed to a home spirometry. So those are the key studies that were included in the 2022 and the 2023 ATS and ERS guidelines, which we shall go into shortly. So now I turn over to nintedanib studies. I'm sure this is one of the studies that everybody has talked about. This is the inbuilt trial, which is nintedanib in progressive fibrosing ILDs. The problem here was that the definition of progressive ILD did not fit what is the standard definition. And they also did not adjudicate for acute worsening or acute exacerbation of IPF. So they could have been included when you're reading this data. But it's a placebo-controlled phase 3 trial conducted in 15 countries. And basically it was placebo against the standard dose of nintedanib, which is 150 milligrams twice daily. And obviously the entry criteria, I've already talked about it, but they had a forced vital capacity of at least 45% and a diffusing capacity of between 30 and 80. But they did not differentiate so much what was called, what they were calling as progressive pulmonary fibrosis. Their definition wasn't the classical definition. And they followed them up for 52 weeks, and the primary endpoint was the annual rate of decline of the FVC. So this is how it was conducted. They screened 1,010 patients, actually randomized 661. Those who finished the studies were a lot less, because those that finished the study, those that were randomized were 332 to nintedanib, 331 to placebo, and those who actually finished, who got to the end, were 300 and what's the number here? Minus 18, because on the nintedanib arm, 18 did not finish the full study, and 20 on the placebo group. Okay. So what they did was they had an intention to treat analysis. So anybody who entered into the study was included into the analysis. But they also had a secondary endpoint where they excluded them, and they were able to show a bigger benefit of the nintedanib. So these were the two groups, if you look, the 332 and 331 at baseline. And basically the groups looked comparable in terms of the gender mix, the age distribution, former smokers or current smokers, and even in terms of the lung function. They basically were almost the same. And I'm showing you the primary endpoint in patients with fibrotic patterns that were not UIP-like, because those were the ones that we are interested here in PPFs. And what they showed is that there was benefit in giving nintedanib to those patients. Their decline was less because it was minus 79 compared to minus 154 in patients on placebo. In other words, or in concluding, is that patients with PPFs given who do not have an UIP pattern, given nintedanib, did get a benefit in terms of a less decline on their FVC. There's also the senescence trial. statistically significant. So that led them to conclude that annual rate of decline in FVC was lower in nintedanib than in placebo patients observed over a 1-year period if your initial diagnosis was systemic sclerosis. So those are the 4 studies that really were included in the 2023. The other studies have not been included. They'll probably be included in the next update. So I shall not talk about the trail and the other studies because they were not included in the guideline. And I actually want consensus. I don't want argument. So I'll look at 2, first of all. First of all, I'll start with the American because the American is the world superpower. I'm not sure whether we should have Chinese, but maybe next time I'll put Chinese as well. That is if we have, and I'll not put Japanese, but I'll have American and the European consensus guidelines. So these were released in 2022. They include those studies, and it was a guideline for both IPF and progressive pulmonary fibrosis. And what they say about pirfenidone, I'll break it into various things. So the first thing is they say, in terms of disease progression, the meta-analysis basically puts the 2 studies together. That is the unclassified ILD and the relief trial. And basically shows that pirfenidone reduces or decreases the FTD decline by about 100 mils in a year in patients who are given pirfenidone. 100 mils in 6 months, because the other study only had 6 months. So they capped it at 6 months, yeah? And this is about, it means if you just look at the unclassified ILD, that was the second study, pirfenidone decreased the decline odds by 1.6 compared to the placebo, okay? And they had a cutoff. They had a 10% decline and a 5% decline. And basically they say 5%, 1.6, and in 10%, 1.9 decline. So that is in lung function. In mortality, there was no difference, and there was no mortality difference between pirfenidone and the placebo, okay? Nothing was statistical. Relief trial only gave us numbers, 1 dying in the pirfenidone, and it did not reach statistical significance. So basically, in terms of mortality, pirfenidone might not give you much of a change. In terms of lung function, remember the relief trial, its primary target was home spirometry, which did not change, it was negative. Although when you analyze the secondary endpoints, which is basically the spirometry at the study site and the DLCO, there was a tendency towards reducing the decline in those lung functions. And the combined meta-analysis also showed that basically pirfenidone might decrease the lung function and also increase your 6-minute walk distance. Respiratory symptoms, if you are looking at cough and the quality of life, basically whether you give them pirfenidone or not, there was not much difference. And I'm yet to see a study that improved much of that. In terms of side effects, pirfenidone increased the risks of side effects, okay? And the most significant was photosensitivity by almost 5 times compared to the placebo, but it also increased all the others, including gastrointestinal discomfort, and obviously all the other, including rashes and malaise. Okay, so that's what American Thoracic conclusion in terms of pirfenidone. In terms of nintedanib, this is what the Americans say, that they think it might be a better option for treatment of PPFs who have failed the standard management, yeah? And that was mainly based on 1 trial, which is the inbuilt trial, despite its errors, yeah? So they also take in cognizance that it's usually not the first, and most of the time it's added to other immunosuppressive treatment. In terms of disease progression, they showed that inbuilt showed a mean decline, which was significant, which was 107 mils in the nintedanib arm, more than that in the placebo group, They also showed that nintedanib decreased the risk of progression in terms of lung function decline, 2.4 times compared to the placebo. Okay, and there was more benefit in people who had a UIP-like pattern than in the non-UIP-like pattern, but both groups did benefit. Okay. Mortality, no significant change in mortality in the inbuilt trial. In the Senate, mortality was actually not reported. So we really don't see much benefit in terms of mortality in nintedanib as well. Adverse effects, yes, the treatment increases abdominal and gastrointestinal side effects by about 4.2 times compared to placebo. And I've given you the breakdown, but it also does affect the liver, and the aminotransferases or hepatitis-like picture can occur about 3 times more compared to placebo. Okay, so that's about the Americans. That's what they say about the two diseases. I'm going to put it together just now. In the ERS, which came out in 2023, this was more of an expert group, consensus group, other than evidence, although they did consider the evidence, but it was really a consensus statement than a guideline. So they asked, basically they used questions. And if you look at their question, the first question was pharmacotherapies for treatment of PPF, okay? And what they were trying to ask, what is the management of PPFs or progressive pulmonary fibrosis? And basically, what they were trying to tell you here is that there's no standard treatment, okay? Which basically is what Professor has said. So it's not a one-cap-fits-all, and not all people agree. So there might be differences of what is the initial treatment. And this will depend, mainly can be guided by your multidisciplinary team or your experts on site. Second is immunosuppressive therapy added to a background of corticosteroid, which is a bit controversial, but people do it whenever you have an acute exacerbation, yeah? And obviously, this can be added, other immunosuppressives, and they've been shown to work, including mycophenolate mofetil, but it's a case-by-case basis, and it will depend on the disease type that you're dealing with. The other question they asked is, there any benefit of adding antifibrotic therapy to a background? They said, yes, there is a role and growing evidence that antifibrotic therapy can reduce lung decline regardless of the background immunosuppressive therapy. So it's something that you can consider, although we have more data for patients with scleroderma or systemic sclerosis, ILD. The other diseases, we are lacking data, but we know now we are going to get a lot of data for rheumatoid arthritis, but the other diseases might be lagging behind. Can antifibrotic and immunosuppressants be combined upfront or combined sequentially? I don't know the practice in many centers, but in our centers, usually we start first immunosuppressive and then add the antifibrotics. And I think this was a recommendation that it's not wise, although people also do it. You can do it, that you can start the antifibrotics and the combination therapy upfront. But for most of us, I know we do it sequentially. How do you consider nintedanib versus pirfenidone in consider, apart from the data? And I'm sure some of you have seen this. They talk about the pill load in pirfenidone. At the full dose, you'll actually be taking up to 12 tablets in a day. Okay, that's the highest dose. While nintedanib is just 2 tablets, one morning, one evening. Okay, if you are looking at side effects, both of them have side effects, but remember photosensitivity, much bigger in pirfenidone, gastrointestinal in nintedanib. So you need to consider that. So if somebody is working outdoor, okay, If somebody who works most of the time outdoor, you are better off with nintedanib than pirfenidone. If that person is on anticoagulant therapy, okay, they tended to suggest that you're better off with pirfenidone than with nintedanib because of the propensity of you to get bleeding and other issues when the liver is affected with nintedanib. Although this is just one study, we'll need to see more studies on that side effect. If you have ischemic heart disease, then basically they preferred pirfenidone just because the anticoagulants again were going to become an issue. If you are planning a major surgery, they preferred pirfenidone, which was a bit controversial to me, but they said the liver and things of bleeding and the rest becomes harder with nintedanib. Again, this is it's a statement of experts. Impact of quality of life, they're the same. And if you are looking at acute exacerbation prevention, both of them are the same. So generally, you can pick depending on which one according to the European Respiratory Society. So in conclusion, I know we started by saying PPFs and IPFs, they behave similar. They behave similar. And that's why we were replacing IPF there with PPF. And I remember in the first slide, we had already consensus in the non-pharmacological and in how we are going to monitor the disease. Our problem was more evidence currently for nintedanib, a little bit of tendency towards data that shows also pirfenidone can actually increase your FVC. But it is important when you're talking about PPF is that the first thing you optimize your primary therapy, which is obviously the things that you need to eliminate. If it's a hypersensitivity pneumonia, you need to eliminate them. You need to make sure you have optimized your immunosuppressive therapy. That means you're going to use your steroids, you're going to use your Janus kinase, you're going to use all the other therapies before you go to the antifibrotics. Then you can use your biologics, and we've been shown that, and they're becoming more popular. And then if it's possible, always it's best to treat PPFs in a study setting if it's possible. And obviously, I'm not sure we'll argue about if everything fails. You should always list them for palliative care, as has been said, and list them for lung transplant. Palliative care is a must from the beginning, okay? And where lung transplant is available, you should allow them to list as early as possible. I think that's where I'll end it, and then I'll be ready for any questions.
Thank you, Dr. Nyale. I want to welcome the two speakers of this session, and we can fire the questions away. Online participants, please put your questions on the Q&A. I think Prof. Deloy had a question.
Okay. I have one question for Dr. Nyale first. And I think this worth pondering over. Because the interstitial lung disease is progressive, and we don't have any evidence to the contrary, why can't we add on the antifibrotic from day one? Why do we have to wait when we know where we are heading? Or you mentioned that you will use immunosuppressive and not antifibrotic. Because again, I think for our own environment, I don't know how easy it is to do lung transplants. I'm talking about doing all the other palliative and things we need to, but why can't we start with both of them ab initio?
So
that's good.
That's an option, okay? Or what I said is that even by ERS standards, that's an option. But never forget that in PPFs, we've shown some of them stabilizing for a long time on only immunosuppressive therapy. Not all of them progress, even if you have fibrosis. Actually, if you follow the databases, we actually see progression in between 12 and 32%. That's why you average it at 40. So you have 2/3 of the patients who don't progress It's only a third. Now, the question is, how do I identify this third that's going to progress? That's the question. And you must have treated them for some time for you to show that they're progressing, because the progression measures were shown to you. Now, unless you are able to get data from the beginning that this person has been progressing, the question will be, has he been on any treatment? Let's say you have somebody with rheumatoid arthritis and comes to you, okay? He's not on any medication. You'll obviously expect him to progress. True or false? When you give him the treatment, and let's say you get good treatment, give him rituximab and then mycophenolate to maintain him, okay, are there chances that he'll not progress? The answer is yes. Okay, so in that kind of patient, if you load him with nintedanib, it's a cost, side effects, and you're not assured of a benefit. Okay, I think Prof.
Can I add something on? I must say, I really share your view that waiting for somebody to get worse is a bad idea. I mean, the analogy that I've been told is it's like waiting to see whether the cancer gets worse before you give the chemotherapy. So really, I think what we would like, if possible, because I take your point that lots of patients stay stable, is if we could have another biomarker or another measure that would tell us who would progress without actually having to wait for them to show that they're progressing before we treat them. Because I mean, treating patients when they're already, like waiting for them to get worse to decide that we need to treat them doesn't sound like a good strategy. Yeah. Yeah, but I agree with you.
Then why don't you just start off? You know, maybe if they are not positive, maybe that's a different thing. But if you have positive autoantibodies,
we need that data.
We know that's a bad.
Yeah, we lack the data. Even in IPF, our biggest argument was exactly the same, because we knew it was a progressive disease. The question we were trying to balance cost, side effects versus the benefit. Okay, and remember, people, when they enter these studies, they don't want to die. Mortality is an important thing. None of these treatments have showed a mortality benefit. So what you're trying to say is that I'll give you something, you'll die of the disease anyway, but you might be happy and dance in the meantime, which is pretty good for some people. Okay, so I know it's the same thing. Have a progressive PPF, it's difficult unless we get good biomarkers. Then I agree with you. But the statement is that you can do both. But most of us do sequential. When we see that he's progressing, then we add it. Not that he's gotten to oxygen. When I see your FVC is going down, okay? Now they've gone to 5%. Before we had 10%, okay? Which was, if you lost 10% in 1 year, it was irrespective whether your lung, you are able to go to the gym and jog would start you. Okay, we were not going to wait. When we are saying waiting, is not waiting for somebody to be on oxygen. Okay, we are not waiting somebody to have a debilitating symptom. What we are waiting to see is that the lung function is declining. Okay, so you might have somebody who will come with a forced vital capacity that's 130 above, which is way above the predicted. But if this guy comes to 110, which is still much better than his peers, he has deteriorated, and now you can start him on your antifibrotic as well.
Thank you, thank you. Can we move to the next question?
Prof. Have we answered you, or it's still up for discussion?
I've listened to you. I see that because again, our own population.
So you want us to do like hypertension. So you see this, the strategy in hypertension, whether we should sequentially treat them, or it's called fire, or the other one is called what? There are two strategies in hypertension, whereby fire is they come in and you hit them hard, pressures come down, then you can scale down, or you can continue adding and scaling up. And in Africa, people chose the fire strategy, where somebody comes, is BP's 175, you give triple combination. Let them come down and you scale down, because they might never come back to you. It's a strategy, and probably we need a study in Africa.
Yeah. So we'll have Prof. Bika and then Dr. Abdulaziz.
Okay, I just like to ask about endpoints for clinical trials, and I know FVC is fairly predictive of progression, disease projection when you compare with the secondary endpoints in the same trials. And I know DLCO predicts mortality, but it has its own problems with the logistics and the
Yeah, I agree with you. I mean, dyspnea also correlates with mortality. Cough also correlates with mortality, and I think you're right. What we need is a composite endpoint. I mean, it's disappointing that we've got drugs that slow lung function decline but don't make people feel better. I mean, that's not acceptable. That's not a patient-centered outcome. So I agree with you. We're going to have a composite endpoint.
Yeah, so there will not be one endpoint. I think it will be combined. And I think we should go the same way the diabetologists and cardiologists have gone. We should demand that for any rheumatologic investigation, lung diseases outcomes must be there. So that it is impossible for you to do a rheumatoid arthritis trial without lung function testing. I think that should become mandatory so that we get data quickly and that can help us, because the rheumatologists have more studies than the pulmonologists. Yes. This in PAS and to ERS and to ATS, that rheumatologists stopped doing any trial. It should not be approved by any ERC until it has pulmonary outcomes.
All right, let's go to I'm trying to rush because of time. Okay, Dr. Abdulaziz and then Dr. Tina.
Okay.
Maybe you can ask the two questions so that the panelists answer.
Yeah, the other concern is if the patient is feeling better and is now doing well, and is telling you, why should I continue taking this expensive medication? Like, how do we convince them that this is a lifelong treatment and they're doing well, their lung functions are okay, and their symptoms have resolved?
It's making me think of something. I just wanted to respond to the previous question. And we must be a little bit careful of patient-centered outcomes, because in the Panther trial, I mean, the one that showed that patients did worse and had more complications if they were on triple therapy, patients who received steroids all felt better at 6 months, even though their lung function was declining at the same, because people feel better when they're given steroids. So you know, sometimes, and I mean, they've shown that in asthma studies as well, that people's lung function may not get better and their ACT scores might not change, but they report feeling better on certain medications. So I think we must, you know, decide what are important patient-centered outcomes that aren't going to confuse the picture. So, I mean, like with your patient, I mean, is his appreciation of his improvement really really showing what's happening with his disease progression? And the answer is we probably need a mixture of both.
So people feel many things, and sometimes these drugs have a high effect, yeah? So they might feel better, not because the treatment has changed anything. Maybe somebody added some codeine to his therapy, and now he's feeling less pain, he's feeling a little bit high, and he's feeling the world is good. And it has nothing to do, because usually these other therapies you don't control. But it's, so what I usually tell patients, because I've been faced with this many times, especially with IPF patients. I have patients who come and tell me, I can't afford this drug, I'm better, I want to stop it for a while. Now I tell him one thing, yeah? You are holding a lion, but you are not holding its head, you are holding its tail. Okay? Now if you are pulling a lion by its tail, I'm not sure if you want to really release the tail, because many things can happen, okay? Now, so if you want, we can release that lion, which is the disease you have, but things might happen to you. So if you are going to do this, how are we going to monitor you closely to know? But he should be informed that if you are going to do it either for cost or for any other reason, things can happen to you. And my question will be, how frequent will I need to see you? How often when you stop this drug? And when should we start it at the earliest symptom? And I always tell them a second thing, because I have seen this, I don't know if you people have seen it, that patients with IPF do very well the first time you give them the antifibrotics. When they stop, they come a second time you give them, they don't do as well as the first time. And I've been then they come back, you give them the same medication, they don't do as well.
I don't know about that, but in the pirfenidone studies, like all of the improvement was seen early on, and then afterwards it kind of all settles out. So,
yeah. So
Okay, so I will allow the question from Dr. Atina and Dr. Simani. Please ask the 2 questions. We have another session.
Thank you. Mine was actually a comment. Abika was saying earlier, in my view, maybe the most important endpoint in this, at least in this local setting, is death, is mortality. People are not asking for anything else. They are more interested in mortality, and none of these drugs, I think, has an effect on mortality. And I think I would like Dr. Nyale, maybe the better example is not hypertension, it's probably lung cancer. So I think it's important to tell the patient this drug is going to slow progression. You're going to progress essentially. They're just slowing it down. So, and perhaps we should not be like maybe the oncologists do with the stage 4, stage 3, they start them on chemo. They don't tell the patient we are doing palliation. The patients go thinking we are looking for cure. So the end point. So that's my comment. Thank you.
Dr. Simani, please go ahead.
Mine's going to be very brief, actually, and it's to all the speakers. In Africa, patients have terrible choices to make because poverty forces people to make priorities, choices all the time. And I think we have to be careful that we're not introducing patients and putting them into situations where they have to make terrible choices. If you have say a woman from a rural area, she has 5 children, she has education of children to think about, she has other issues, and then she has fibrosis. Shouldn't we think carefully before telling her we have this nintedanib, we have pirfenidone? Shouldn't we think carefully? Who's going to pay school fees if all the money now goes into the medication? How about the other priorities? I think we need to think carefully. And this is where the wholesome approach is very important. We have to prioritize, and we have to ask ourselves, will this patient benefit from this? It's easier in the West because you have insurance and governments pay for some of these treatments. But here, it comes from out of pocket. Thanks.
Thank you so much for your comments. I think I have one last question, and I'm asking on behalf of the residents who are here. TB risk when you're treating these patients. Since we come from a very high TB burden setting, what's your experience? I want to seek South Africa's experience. And do you usually do IGRA testing for these patients? If you do, and if you do IGRA and it's positive, do you usually give TB prophylaxis? Prof. Adelo, you can also comment.
Okay, I'll answer on the South African setting. I'm not sure of the TB incidences in your country, but in Cape Town, we've got one of the highest incidences of TB in the world. It's 1,500 per 100,000 people. So almost 2% of the population get TB every year. We don't test for latent TB. I mean, we've got a latent TB prevalence over 85%. So we don't think it's worth doing IGRAs before, but plus we think that giving INH prophylaxis does 2 things. It treats latent TB in the patient on immunosuppression, but it's also TB prophylaxis. So I think I would give it to somebody even if they were IGRA negative for TB prophylaxis. So anyone over 15 milligrams of pred gets 300 milligrams of isoniazid and also Bactrim prophylaxis for pneumocystis. I think the American College of Rheumatology say that if you're on more than 16 milligrams of prednisone, you should be on pneumocystis prophylaxis as well. And unfortunately, we have seen that even in HIV negative patients. So I'm not sure whether it's applicable in your setting depending on your TB prevalence, but we give everybody isoniazid who's on immunosuppression, not antifibrotics.
Yeah, no,
Guideline, no, not a guideline.
No, we don't give any prophylactic. We do the test if the patient is going to go on biologics or the JAK inhibitors, but we don't do the tests just routinely when they come in. But invariably, by the time they start having difficulty in breathing and cough, even before they are referred to you, they have done the tests. So if you want to rely on that, then that's it. But we don't, except they are going to go on immunosuppressives.
Thank you. Can I just say that data for us is extrapolated from the renal transplant literature. So it may not obviously apply to ILD, but they've shown in Cape Town that renal transplant, in fact, even dialysis patients get much more TB. So that's where the INH prophylaxis comes from.
Thank you. All right. So if you allow me, I will go on to the next session. The next session is a more interactive session. Yay! All of us, yeah? Let's clap for all the speakers, please. Mary, are you leaving when we need you? All right, so I think to start us off, we'll have Dr. Zifa. Dr. Zifa, are you online? Dr. Zifa? Dr. Zifa, if you're muted, we are trying to reach you so that you can present your...
Here, but my resident, Dr. Isian, is the one presenting. So he's on as the other Dr. Zifa that you can see.
All right, so you can share and go ahead.
Can he be made a host? Can he share his slides, please? Otherwise, I'll try and share.
What is his name?
Okay, give me 1 minute. So I'll share for him.
Yeah, that would be great. Thank you. Dr. Zifa, I see your, Dr. Fosson, yes, I see your hands raised.
No, I haven't raised my hand. I'm sorry to say.
No worries.
I think that might be the person to present. I don't know.
Dr. Zifa, do you allow us to start with someone else as maybe the IT team tries to sort out the presenter? We can do one presentation and then you'll be next. Is that okay? Zifa, Dr. Zifa. I think we can start with one presentation. Prof?
Prof. Bandero, you can start with one of your case, one or two. You can just one.
But it's not really a detailed history, just a summary.
One or two?
No, we have two.
Yeah.
Each one is addressing certain questions. Okay, this is the first one. And the case goes like this. Mrs. H.
Let me share the screen.
If you would make the other one rather the co-host to share.
Yeah, Mrs. HY is a 60-year-old businesswoman who was diagnosed in the teaching hospital, scleroderma in the teaching hospital. She later developed recurrent dry cough, exertional dyspnea, and dyspepsia 2 years, which lasted for about a month. And those are the results of the investigations. The HRCT said non-specific. Lung spirometry reported mild restrictive lung disease, ANA, antibodies, 1 in 5,120. The normal should be 1 in 80. Anti-CL70 is positive, but FBC is normal, and every other thing looks normal except from mildly elevated AST and ALT. So it was started on methotrexate, tocilizumab, low-dose prednisolone, because we always were worried about prednisolone causing scleroderma renal crisis. So we don't use that. And then we use nifedipine. Although Dr. Greg said we shouldn't use it that we shouldn't use pirfenidone, not to be used in scleroderma, but pirfenidone. Yeah, okay, this patient was on pirfenidone, really. No, I'm sorry, not nifedipine. This patient was pirfenidone. We did use it because we didn't have any option. So then later she developed productive cough with hemoptysis. Repeat chest CT scan showed features of ILD, and gene expert was not detected. Chest X-ray, I can't see that one. Can you take off that pop-up? This one. Let me just move it up. Just move up the slide so I can read. Okay. It showed, okay, hypertensive heart disease with background ILD and these are the themes. Yeah, these are the themes. So the additional treatment, was pirfenidone. At this stage, that pirfenidone was used, despite the report that it should not. And then we also put on prophylactic antimicrobial. The repeat HRCT 4 months later, the same features of ILD, low predominant ground glass opacities, and this is where I think our radiology colleagues come in. Low predominant ground glass opacity, bronchovesicular opacity, and traction bronchiectasis extending from lung bases, minor honeycombing and subpleural reticulation, which would this would qualify for UIP. Am I right? Or NSIP, because initially we said it was NSIP, and then by this time we are seeing UIP. This was what we got, months after the first one, showing definite evidence of UIP. The lung spirometry, interestingly, was normal, and she still continues her medication, which essentially she's still on pirfenidone, and we sometimes put her on low dose prednisolone, very low dose, 5 milligrams, to take care of occasional polyarthritis that she gets. So this is a case of a definite systemic autoimmune rheumatic disease that is using the current biologic of tocilizumab, and that's because the HMO authorized us to use it. There are other HMOs that don't authorize such expensive medications for us. So that's our story. That's a typical one. Yeah. Should we discuss? Yes, please.
Can I be controversial? My understanding is that not everybody with scleroderma and interstitial lung disease should be treated because there is a percentage of people who won't progress. So the criteria for starting treatment are people that present with an FVC that's less than 60% or DLCO that's less than 50% at diagnosis, or if they showed progression. So I'm just interested, was this somebody who was given upfront treatment based on their scan, or did they show reduction in their lung function even though they were at normal or supranormal levels?
It was more because of the symptomatic progression. It was more because, not because of the HRCT, it was because of the symptomatic progression. What maybe, and then we don't have DLCO. We don't have facilities for that in the hospital where I practice, so we couldn't do that. So you would think we shouldn't really have started on the biologics,
Well, I don't know. I mean, I think you obviously had a reason to start. I mean, my question is just whether you could stop. I mean, you said she had some benefit on tocilizumab, but whether you actually start removing treatments and seeing whether she remains stable. Because, I mean, the way I understand it is the longer you're out from your scleroderma diagnosis, and if you haven't shown progression, the less likely you are to progress. It's just a thought.
Okay, maybe I missed the point. She was actually started on the synthetic DMAR, and into tocilizumab. So I got that was missing in the.
Just a derived and see if the benefit would be bigger, and if the progression of the ILD, because you're showing 2 scans whereby the picture or the fibrosis got worse. So would that have been an option to scale it up and see probably in 6 months what is happening to the CT scan?
Yeah, you're right. You're right. We should have stepped it up. You're right. I quite agree with that. You're right. So when I get back, I'm going to review and see what we do with the.
Prof, if the medication, she gets better after 6 months, will you stop?
I'm not so sure we will stop.
And
I don't think we will stop. The only drug we might stop is tocilizumab if the authorizing body, the body that's paying, saying, look, it's getting too expensive for us. But she's been on it now for close to a year. And each time we say she needs more, they don't deny. With tocilizumab is to increase the interval between the dose. Like she's now taking it once a month instead of every 2 weeks.
Just another question. In most of the idiopathic pulmonary fibrosis, all those studies included a good number of patients with scleroderma. So whenever you're looking at those studies, these were your typical patients. Scleroderma patients were a big number in those studies, if you look at those studies of IPF, the initial studies. So I think you are very safe with scaling up Pirfenidone.
Pirfenidone.
Now the question is, I'm not sure why you didn't opt for an oral Janus kinase inhibitor for this. Why not give him?
Well, the JAK
baricitinib?
inhibitors have not really been authorized by any of the body. It's only tocilizumab and even rituximab is not.
Okay.
You know, rituximab is just hanging in there, but despite the fact that it's not FDA approved for so many conditions, it's still the commonest drug biology that we use. But tocilizumab has. The JAK inhibitors are not. They're still all experimental. That's why we didn't use it. And it's on the long run, it's actually more expensive for us than the tocilizumab. Well, I don't know whether
did you consider a lung biopsy in this patient?
No, we did not. We don't have the we didn't have this. Well, we didn't call in any of the surgeons to do so.
Okay.
Because we already have the HRCT evidence. And I think one of the presentations we said that if you have HRCT evidence, why would you want to do a lung biopsy?
So with an MDT decision that agrees with you?
Yes.
Okay, thank you.
Okay.
Thank you, Prof.
Thank you.
Thank you so much. Let's give him a clap. So next, Dr. Zifa, is your team ready?
Yes, we
Dr.
are
Zifa,
ready.
good. You can share, please.
Okay. So Dr. Ian will present on a case of systemic sclerosis with interstitial lung disease. We hope that this will take us through the pattern of systemic sclerosis, ILD, the complications associated, comorbid problems, the lungs, and then how the management strategies were and what we could have done differently in this case. Dr. Ian, please go ahead.
All right, good evening.
Good evening. Just in the interest of time, we have 10 minutes for each case. So I see there are 23 slides. Make it 10 minutes, please.
Okay. Okay. So I present Mr. SM. He's 52 years old. He presented to us with recurrent difficulty in breathing of a week's duration and also worsening cough, also for a week's duration. So he's been having difficulty in breathing for about a week, which progressively worsened. Also been having a persistent cough, which was worse at night and associated with chest pain for the past 6 years. And for this, he's seen several doctors over the period, and the cough had also worsened prior to the week he presented to us. And then also of interest, 5 months prior to presentation, he noticed darkening of the skin and thickening of the skin on the hands and the abdomen, and also some hypopigmented lesions around the mouth, the chin, and then the legs. He also had pain at the tip of the fingers, which was associated with cold weather as well. He had fever, autopnea, PND, weight loss, but there was no night sweat, no contact with person with chronic cough. He had palpitations, easy fatigue, and dizziness as well. So for past medical history, as mentioned earlier, he's been to several doctors. In 2018, he presented with chest pain, epigastric pain. At that time, was diagnosed of angina pectoris and GERD. Was started on pantoprazole, clopidogrel, and atorvastatin. Then November 2018, the epigastric pain was persistent. He did an upper GI endoscopy which showed pangastritis with 8 pylori, 2 for 8 pylori being positive, and then triple therapy was started. Then in 2021, presented with easy fatigue and palpitations, chest X-ray done at that time showed cardiomegaly and bilateral patchy opacification. At that time, we're in the COVID period, and the COVID test was positive, and then he was treated for that. And then in February 2022, he developed palpitation, hot flashes. Echo then showed mild pulmonary hypertension with dilated right ventricle. Pulmonary pressures were elevated, 49 millimeters of mercury. Ejection fraction done was 69%. And thyroid function test done was normal at that time. Then it was started on bisoprolol 2.5 milligram and then sildenafil. There's no previous surgery. So at the time we were seeing was on the sildenafil 25 milligram BD and then the bisoprolol 2.5 BD. Social history, so he was married. He is a vegetable farmer, but due to the illness, has stopped working for the past 2 years prior to presentation. So on the time we saw was a middle-aged woman, chronically ill-looking, was on oxygen at that time via nasal pumps, was pale, no jaundice, rehydration fair. He had hypopigmented lesions over the malar area and also over the nasolabial fold and the chin with scaling. He had dystrophic nails as well, stage 4 dictal clapping, and thickened skin in the hands and the knuckles as well. The other features were suggestive of a tinea infection. So of interest on the respiratory system, his respiratory rate was 24 cycles per minute. Saturations were 93 on oxygen via the nasal pumps at 5 liters per minute. Trachea was central. Expansion was equal in all zones. He had dull percussion notes in the lower lung zones, especially on the right. Then the vocal resonance was also increased in the lower lung zones. Breath sounds were vesicular and intensity was reduced anteriorly in the right hemithorax and posteriorly at the right middle zone and lower zone. Then he had coarse crepitations in the middle to lower lung zones. Other systems were essentially normal. At that time, made a diagnosis of systemic sclerosis complicated by interstitial lung disease and then pulmonary hypertension and then gastritis together with the pneumonia and the tinea vesicular. So we started electrolytes osteocare, then also fluoxetine and GTN paid for the Raynaud's phenomenon, and then antibiotics, amoxiclav and azithromycin. The aim was to gradually wean off oxygen at that time, and the sildenafil and the bisoprolol was continued. So these are the labs. The important one of interest to us. So putting for gene expert was negative. A CT scan, it came with a chest X-ray and a CT scan. The CT scan showed the bilateral symmetric ground glass changes, patchy fibrosis and microcystic honeycombing with an epicobasal gradient, suggestive of interstitial lung disease. And then the immediate subpleural sparing is suspicious for cellular non-specific interstitial pneumonia. So this is the chest X-ray. You can see the heterogeneous opacifications from middle all the way to the lower zones bilaterally. Then this is the image of the CT as described earlier. All right, so the respiratory team and the gastroenterology team was involved. After the 6-minute test and other workup as well, it was determined that the patient required long-term oxygen. He gets quite breathless when he's off oxygen with minimal activity, but was discharged on long-term oxygen at home. Progress report, he's been admitted twice on account of worsening of the symptoms. The first one was just on account of pneumonia. The second one was on account of heart failure, confirmed by symptoms and then the echo that was done when he came in. And then pro-BNP was also elevated. The initial ejection fraction of 69 had dropped to 4:1. And then pulmonary pressures had also increased. And then the right-sided heart chambers were also dilated. All right. So that was the diagnosis made. After the assessment, in relation to At that acute rate, the pneumonia was managed for with antibiotics. Perfenidone was also started at 200 milligram TDS. Patient actually got better and was discharged home, still on the LTOT, but the oxygen requirement had not increased. He was still requiring about 4 liters per minute on nasal pump with his daily activities. But upon further assessment later on, she was initially on azathioprine, which was changed to mycophenolate mofetil, and then still having reviews with both the rheumatology and the respiratory clinic team, and also gastroenterology because of his chronic B infection. So currently, these are the medications that he's on: mycophenolate 1 gram BD, prednisolone 10 hydroxy 200 milligrams daily, sildenafil, osteocare, and the other ones based on the other comorbidities the patient has. He still requires oxygen at home, but the rate is still between 3 to 4 liters now. The recent chest X-ray we had still had the palpitations in the middle to lower lung zones. Doesn't seem to be worsening from the previous one shown earlier. Thank you.
So our questions were whether in these patients, given the diagnosis of the pneumonia and so on at the beginning, was it safe enough to have done cyclophosphamide? We opted for azathioprine because that was a cheaper medication that he could afford. His hepatitis B was positive as well, so doing cyclo was a concern. And so in the end, later on, because the lung function wasn't improving, we had to switch to mycophenolate. I think there's a debate currently as well regarding starting immunosuppressive therapy early together with antifibrotic therapy, whether in this patient that the history was so long-standing, pirfenidone could have also been started earlier. So the dilemma here was how to manage infection risk in this context of immunosuppressive drugs, starting both anti-fibrotic and immunosuppressive therapy early or concurrently rather than later. And in terms of medication treatments, what is best as we know for systemic sclerosis. Thank you.
Any comments from the team?
Yeah, I would like to ask them, yeah, because well, they haven't gotten worse, but by now they have a few features of progression. Are they considering getting an antifibrotic for this patient?
So we started on pirfenidone, which is what is readily available because we don't have Nintev PS. So he's on pirfenidone now since December last year.
Okay. Well, I would have preferred Nintedanib if it was available because you've got more data.
Definitely,
yeah.
Definitely.
But here again, you have to keep on scaling it up and seeing if you continue getting better benefit because higher doses give you better benefit.
Yeah. Okay.
I have a question, Dr. Mbati here, radiology. From the description I saw, well, the images are not so clear, but I read the description. Is it possible that it's probably, because I read that you said subpleural cyst, honeycombing, so is it possible that it could be UIP with some active inflammation going on because you have these ground glass changes? Because if I read the description, it sounds like a UIP pattern of interstitial lung disease. Yeah.
We just show the images. Well, this was the radiological the radiologist's comments on it being,
but from the X-ray, I didn't see a lot of. I saw that the bases were spared.
Okay, from the X-ray, yeah.
Yeah, from the X-rays, the bases look spared. In fact, at one time, I was seeing more of the infiltrates in the middle lobe, and I was wondering, should we put this patient on PJP prophylaxis?
Mm-hmm.
Because
That's a
it
good
looks
consideration.
like a battering, and I
Yes.
was wondering, do we really need to put PJP prophylaxis on this patient?
On this patient as well.
Yeah, because you see, it's in the middle. The
Mhm.
base is,
Even
looks
the
a bit
CT chest,
squared.
yeah, even the CT chest, you see the lung base, the bases look rather clear.
Mm-hmm. Okay.
So I think PJP would be a good trial also to
try as well. Okay.
Yeah. Are you able to get a BDG, a serum beta diglucan, in your country?
Unfortunately, not yet.
Okay.
Can you try and zoom? I don't know whether Dr. Mbati, can you see from there?
No, yeah, it's okay. Now I can see her.
For the,
All right.
for the rheumatologist, would you start cyclo in the context of active hepatitis B?
You need the mic?
I wouldn't mind starting it because, I mean, both of them are immunosuppressive. And for us, I don't know when you say that cyclophosphamide, that MMF was cheaper because cyclophosphamide is cheaper. You give it as IV, once a month, depending on which regime you are using. Sometimes we use the urolupus regime. If you don't think it's serious enough, that's 500 milligrams every 2 weeks over the next 3 months, and then we continue with the oral. But there's been no study to show there's non-inferiority between the two of them, and I'm not so sure whether there is more likelihood of infection between cyclophosphamide and MMF. I'm not so sure. Maybe some others have such information, but I don't know. You have information?
No, so he was actually started on azathioprine because that was cheaper, and cyclo was avoided because of the infections and the hepatitis. And so later that was switched to mycophenolate, given the evidence for improvements. We persuaded him that that could be something that was going to be beneficial. So he found the money for that. So it wasn't cyclo versus MMF, was rather ISA versus the MMF consideration. Okay.
All right. Are you happy, Dr. Zifa?
Yes, we are.
All right. So we'll move on to the cases from Kenya. This will be presented by Prof. Bwika.
Thank you. I hope today's talks are going to be pertinent to what we have. So this is a case of a patient whom we discussed in our national ILD MDT. And I'd like to seek your opinions because the patient has evolved somewhat. So this is a 56-year-old gentleman who presented with a dry cough for 7 weeks and unintentional weight loss of 7 kilos. He'd had occasional fevers, and he was admitted due to presyncope with a cough. And he also had the cough during exertion and also during rest. He was hypoxemic and dyspneic at the time of admission. He had bibasal crackles and his saturation was 193% on air. He was worked up. He came in under the care of a diabetologist who diagnosed diabetes in that admission, and he had cardiology workup for he had been diagnosed with a psoriatic arthropathy 2 months earlier and had been taking leflunomide and methotrexate for this. The diagnoses were done outside, away from Aga Khan, and there was no other family history or prior history of a connective tissue disorder. So his current medications at the time of the MDT, that was in February. He was on subcutaneous insulins, which is since grown out of. He was on oral codeine, which was started for the cough. He was on levocetirizine, on dansetron, aspirin, and the rest of it. And the pneumotoxins he'd been exposed to prior were the methotrexate and leflunomide. His occupation was he was a C-suite executive. He traveled a lot. There were no other industrial or organic dust exposures in the history. He's never smoked. So we have lung function there. You can see he has a restrictive, slightly restrictive spirometry, and this was very mild on gas transfers, and he's on lung volumes by gas transfers, and his gas transfers are shown there. By diffusion, and his gas transfers are shown there. Not significantly reduced on KCO, but you can see the DLCO was 60% predicted. So he had a 6-minute walk test, and he'd done 440 meters on the walk distance, and there was a desaturation to 79% after the 6 minutes. So he had a serology workup, and you can see he had a positive ANA just at 1 in 160, and he was positive DFS 70 antibodies and Smith antibodies and ribosomal P protein antibodies on the ENA. His echo had shown multiple wall motion abnormalities with a slightly reduced LV ejection fraction. There were no valvular lesions, but he had a cardiac MR which found low normal biventricular function with a slightly elevated right ventricular pressures. And he had bronchoscopy, and the lavage showed a predominance of 70%, which is more or less in keeping with hypersensitivity pneumonitis if you exclude tuberculosis and sarcoidosis. So we asked the MDT, is this a CTD-ILD? And what do you think? I'll let Dr. Ombati talk us through the images.
Yeah, maybe I can just move closer. Or so we started with a chest radiograph for the date shown there. Basically, in the chest radiograph, we didn't see much. It wasn't very contributory. The lung parenchyma looked normal. Then after that, we went ahead and did a CT chest. This was just 1 day after the presentation. 1 day after having the chest radiograph, and the predominant findings on this supine HRCT slices is that you can see there were some very subtle subpleural reticulations. They were most prominent towards the lung bases. We felt that there were a bit of some mild mosaic lung attenuation, but it looked more in the dependent lung. Sometimes you might see that when you do a supine HRCT. Because of the subtle subpleural reticulations, just to make sure that you're not looking at dependent atelectasis, we went ahead and did some prone views, and again you could see that you still have those subpleural reticulations, so ruling out that's just due to dependent atelectasis. Again, you can also see, as expected, some of the mosaic lung attenuation or the increased density towards the dependent areas, as expected, but sometimes you can also see that in some patients with pulmonary edema. So you really have to rule out pulmonary edema when you see that. So in view of this subpleural, the predominant appearance was of reticulations, no honeycombing, no significant action bronchiectasis. So we thought of it being indeterminate for UIP. We didn't see extensive ground glass changes, but predominantly it's just some subpleural reticulation.
Yes, please. Yeah. Say again? Oh, yeah. So it was a 60% predicted. Yeah. Right. Okay, then. So the consensus from the national ILD MDT was that this is more likely to be a hypersensitivity pneumonitis than a connective tissue disorder. But the rheumatologist felt that he did have lupus. So given the rarity of SLE ILD, we went with this. So we managed him as lupus, and we agreed to look after him in the clinic. So we followed him up over time, and then he came back. So he came back in end of April. He did a 6-minute walk distance, which was marginally better. So, but he walked a less distance, but he desaturated. He did not desaturate. So that's one of the problems with 6-minute walk distance. Sorry, 6-minute walk test. But the key measure is the actual distance, and his distance had gone down. So we have top left the complements, and you can see they were normal before. They were high when he came back recently in June. And you can look at the ESR, the evaluation of the ESR. We had another lung function test on the 30th of May, not April. That date is wrong. So you can see, you can compare the two, the one from 23rd of February and the one from 30th of April. And you can make your own minds up. That was the panel, top right, from the ENA. So we'll now, once you're ready, we'll show you the repeat imaging done recently. Just say yes and we'll do that. Okay.
So I can just describe it from here just to save time. So this HRCT images were performed 3 months afterwards, also in February. Now this is in May, and you can see we are coming from the lung apices going towards the bases, and you can appreciate that the subpleural reticulations has progressed, and even now just showing some ground glass changes. Again, we don't have any. This again shows there's no subpleural cyst, no honeycombing, no traction bronchiectasis, but you just have the progression of the subpleural reticulations. It looks rather asymmetrical if you compare the two sides. I think there was a sagittal image in the next that just shows, again, you can see the progression, and now you have more of some ground glass changes intervening those areas. And there's relative sparing of the upper lobes. And the immediate basal lung is also spared in the process.
So apologies, we can't show you the actual images outside the hospital, but we hope these suffice. So here are the questions to you. One is, was it really a hypersensitivity pneumonitis? If yes, why the progression? And is it really SLE? I'll add value input from the rheumatologist. Why is a lupus activity quiescent now when he has clearly progressed from his lung disease? Is it SLE ILD? And we know that it's quite rare. ILD in SLE is quite rare, and it's commonly NCIP, LIP, and OP, organizing pneumonia. Usually has a relapsing remitting presentation. And you'd expect that with lung disease progression, you also see serological progression of lupus. I think that is common sense, yet we don't have that. So would you use antifibrotic for him? What will you treat his autoimmune disorder? Are you happy with what treatment he is on? Which I hope I showed. And would you biopsy at this point? Thank you. Great.
Yes, this is SLE. 2 points. The rheumatologist said so. That's a joke. But secondly, there are three major serologies we use in SLE. ANA, which in this case is positive. Anti-Smith, which is also positive. Double-stranded DNA is negative, but that doesn't mean, because double-stranded DNA is, although it's specific, but it's not sensitive. Anti-Smith is specific. There are few, I can't remember another condition that would have anti-Smith positive. ANA is sensitive but not specific. And at 1 in 160, normal should be 1 in 80. That's already showing signs that, first of all, let's start with ANA being positive is an autoimmune disease. The next decision, what type of autoimmune disease? And anti-Smith would answer that for us by saying this is positive. That's be my own. And in terms of the other questions, yes, it is uncommon because, like we mentioned in our own report, despite the fact that the majority of patients were SLE, it was less than 10%. I can't remember the exact fact. Should you use antifibrotic? I would suggest yes. Should you biopsy or not biopsy? I would say no.
So, Dr. Mbati, what is the radiological diagnosis for this? What would you call this? Fibrotic NSIP or UIP, or what would you call this?
So initially, in the very first image, I would have gone more with indeterminate for UIP if I use UIP because it was mostly reticulation that was a predominant finding. But later on, now you're seeing this with this progression, and again, it's still subpleural, but again, you don't have features for UIP. It looked more ground glass, so I was wondering if maybe could it be related to the medication. I don't know if I think we had ruled out infection. So maybe if it could be related to the medication. For hypersensitivity pneumonitis, the distribution was against hypersensitivity pneumonitis because it would have been more of an upper lobe distribution. So for this, I think it's probably at the current presentation looked more of NSIP because of the predominant ground glass appearance, despite the fact that even it's extending all the way to the immediate subpleural lung.
Okay. Just a question, yeah?
Yeah.
I'm just wondering. I know diseases don't read books, and I know people always say hypersensitivity pneumonitis, you'll see it in the upper lobes. But I'm sure there are cases people have seen of hypersensitivity and not having features in the upper lobe. Now, I'm still going back to your BAL. It was mainly lymphocytes.
That's correct.
Okay, and there was no TB.
There was no TB.
Is that what you expect in SLE?
No. So that is actually one of the reasons why people thought that this is actually hypersensitivity pneumonitis. Yeah.
Yes, so I have a theory. I'm thinking the secondary things we are seeing could be because of the drugs the patient was given.
Hang on. Which secondary things?
The hypersensitivities that we are seeing.
Yeah.
That are emanating from the drugs that he was given, either the methotrexate or the leflunomide.
That's what the MDT thought to begin with. Yeah.
And we were supposed to change that.
Well, they were stopped at the point of the diagnosis of HSP.
Yes.
Those two offending medication was stopped.
And it still progressed.
Yeah.
Okay. So in that kind of scenario, I would repeat a biopsy and see.
There was never a biopsy. There was
okay. I would repeat a bronchoscopy, do a washing, and this time take a biopsy. What I would be interested to see is, after stopping the two drugs, is it still lymphocytic? Then look at the biopsy. What are we mainly having? Is it mainly fibrosis or inflammation?
So what type of biopsy would you do? Open lung biopsy, transbronchial biopsy, or transbronchial cryo?
Yes,
okay.
Transbronchial
cryo probe. Okay. Any other thoughts?
Can I ask Dr. Yale a question? Aren't you supposed to see eosinophils if it's hypersensitivity? I mean, from my own simple understanding.
No, it's usually a lymphocyte.
It's actually lymphocytes that you will see.
You don't see eosinophils?
No.
All right.
I'm going to be deliberately controversial, I think, mainly because I'm hungry. I'm going to ask the question to the rheumatologists. I mean, if you've got positive serology, but you don't meet any of the clinical criteria, can you still call it lupus? Can you still call it lupus if they don't? I mean, we haven't heard about thrombocytopenia and arthralgia and all the rest of it, because I would have said that I would have said that this was an IPAF, like interstitial pneumonia with autoimmune features. We've got some serology, but we don't have a clinical syndrome that makes lupus, and we've got a couple of different differentials floating around for the interstitial pattern. So I would have thought a biopsy would have been definitely indicated, either cryo or VATS.
But I mean, you asked a question. The current criteria for SLE, both the SLIC, that is Systemic Lupus International Collaborating Clinics, and the EULAR ACR, the starting point is positive ANA, 1 in 80, they say, but we know 1 in 80 is neither here nor there. But then we also know that other supporting serologies will have to be present. So things like the anti-Smith. We don't see anti-Smith in any other condition, as far as I know, and I would want to be faulted on that. Anti-Smith is rather specific for SLE. So because of that, even in spite of the normal platelets, we don't have lymphopenia, which you expect to find. What was the ESR, by the way? Yeah. What was the figure?
So you can see it was 14 at presentation.
Maybe the lupus was under control.
Okay, so this is a question. Whether you biopsy or you don't biopsy or you repeat a lavage or whatever, does it change the fact that, does it change what you do? Because the question was, will you give antifibrotics or not? If the answer is yes, how do biopsies and the rest of it change what you do? Oh,
based on the,
sorry, carry on, please.
Once, based on the histological subtype, biopsy could help differentiate that, for you to see whether there are more inflammatory cells, whether there's more fibrotic. And the biopsy, the histology will tell you as well which of the subtypes is there, which would inform whether these are more responsive to therapy or not. So in case you are trying to decide whether this patient needs to go on immunosuppressive therapy, that will be helpful. Okay.
Okay, my rheumatologist does not think whatever autoimmune disease he has is active right now.
And also tell you the response to therapy if you do start. But for fibrosis, I think maybe that one will not be, biopsy will not help me to decide antifibrotic therapy, 6-minute walk test and so on for that.
Okay, I have one more if you have appetite for it. It's very short. It's a brand new case. It's a bit similar. So this is a 65-year-old lady who came in with a 6-month history of tickly cough, occasionally productive of thick white sputum. Symptoms are worse at night, including congestion. She has episodic small joint stiffness. She had typical Velcro crackles in the bases and inflamed cabinets. There is no, the rheumatologist felt that there was no arthralgia, but she had bilateral leg myalgia, but no muscle weakness, rhinoids, and no other stigmata for CTD. She's had a thyroidectomy done for goiter. Really all, she's on levothyroxine, never smoked, no other pneumotoxins. Those are her PFTs. So again, quite unremarkable spirometry, but and lung volumes, and only slightly reduced gas transfers, which don't completely correct on KCO measurements. She had SATs of 96%, which dropped to 85%, but she walked 530 meters. So her serology was ANA positive 1 in 1,000. And the only other positive thing was the anti-Rho at 52 antibodies. So rheumatologists thought that she could have possibly lupus, but could be something else. So ordered the anti-CCP, which I think is outstanding. and the C3, C4, which were not depleted. So the questions were whether you think we have enough to say this is a CTD-ILD, or these are the imaging. For Dr. Mbati, please. I don't remember from the top of my head. I didn't do, maybe Dr. I didn't do, and Dr. Yeah, he didn't do that either. Yeah.
So you can see the images, the slices are arranged from the apices to the lung bases, and you can also see on the far right you have coronal images, and you can see the predominant finding is that you have this mid to basal lung predominant ground glass opacities, and you have the traction bronchiectasis. We didn't see there's no honeycombing at the immediate at the basal segments of the lungs. Given the findings of predominant ground glass attenuation, some mild reticulation or interlobular septal thickening, and traction bronchiectasis, on imaging, we felt that this was fibrotic NSIP.
Guide me. What do I do? Do we have enough to treat as a CTD-ILD? Do we need to do a biopsy? Yes, please.
I think what we have here is Sjogren syndrome because of the positive arrow and the cytoplasmic ANA, which is a variant when we do the ANA, you know, if you now do the immunofluorescence, that would be suggestive of Sjogren syndrome, and the positive anti-RO is also indicative. Indicative is what we will talk about of Sjogren's. So I think with the two, I would say this is Sjogren syndrome. So it's a connective tissue, it's a CTD. I mean, okay, that's the conclusion. It's a form of CTD. That's the conclusion I would.
Okay, Dr. Simani, you are in agreement? You concur?
I concur it's a connective tissue disorder, but I'm less quick to say that it is Sjogren. I think, first of all, they thought it was lupus. I wouldn't, CCP, are we thinking that it's rheumatoid arthritis? Why CCP? If you think that it could be lupus, then the other approved specific antibodies are antiphospholipid antibodies. Those are well, there's the ENA profile. There's the ENA profile, and then apart from the ENA profile, antiphospholipid antibodies are also approved in exploring whether or not it is lupus. Then you have to go to the history if you want to know if it is Sjogren. Does she have Zika syndrome? Does she have dry eyes?
No.
Did she complain of dry mouth?
No.
You examine the face. Does she have any parotid swelling?
There's no stigmata.
Okay, so then I would be very cautious. Cytoplasm, does she have any GIT features? Because she has cytoplasmic pattern, you have to go and think also about examine the liver, the GIT, and see if there are any GIT features as well. Yeah.
Okay, so I think the differential was anti-synthetase. Does that? Yeah. No, no. Okay. 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 I did the anti-CCP. The rheumatologist did not do that. I did that. Okay. Yeah. Yes. I think it's the most common cause for that type of fibrotic lung disease, is it not? And I know lung disease can predate the other features of rheumatoid disease. So I think it is a reasonable thing to do. I will ask my rheumatologist to call it something. Okay. But whatever it is, it will help me get a diagnosis. And I always ask rheumatologists, I have a patient with an ILD, what are the initial screening tests I should do for CTD? What are they? And I get varying results. But one of the things I was given was anti-CCP. In this meeting, was I not? There you go. Yeah, yeah.
Well, ICCP is not for collective disease, it's for rheumatoid arthritis. And then you need to have more clinical evidence for rheumatoid arthritis.
Okay, you need to recognize that it's a very common. So somebody said 50% of rheumatoid arthritis have lung manifestation.
Yeah, but you have to meet the level of rheumatoid arthritis first.
And we see a lot of lung disease, interstitial lung disease, predating the peripheral other symptomatology. So I have to reconcile that in my head.
Just a question, yeah?
Yeah.
Just a question.
Yeah.
So if it's essentially not because so also this serology will predate the manifestation of an RA.
Okay, to wrap this up, what serology need I do more or wait for before I consider doing a biopsy?
Yeah, I was asking a question because I think I didn't get the beginning of the case, but I'm wondering, I just wanted to come to the defense of the pulmonologist because he's not a rheumatologist. What he did is see the lung, and he looked at the various databases that we have of ILD, and the people with CTD-associated rheumatoid arthritis is the most significant. I think that's what, and that was the reason why in the last meeting, we told him we need to do an anti-CCP because we didn't know better, but probably now we can get his, what is the basic panel? Is it an ANA and an ENA? Or is it an ANA and a rheumatoid factor? Or is it an ANA, or is it a history and an exam from a rheumatologist?
That's a really good question. Thank you.
There's more specificity really matters in terms of
Yeah.
Is it not possible to go ahead and start treating this patient with the information we've got?
But that treatment, well, she's already started on I think mycophenolate.
Yes.
And you can see there prednisolone. That's already started.
Yes.
Yeah.
And then we wait. Sometimes in rheumatology, you wait.
Okay, I think the idea of a biopsy is important because the earlier you have a definitive diagnosis, the better. Okay, and we always wonder whether the architecture changes with immunosuppressive treatment. I don't know. I don't know what you think, Prof. Yeah.
I was just thinking that I was going to ask you my thoughts.
All right.
But I'm not 100% sure. I think I could be swayed either way.
Okay.
Is the patient progressing after those mycophenolate and prednisone?
So this patient is barely 3 weeks old.
Okay.
Yeah.
And you started this before you had not been on anything?
No, she only levothyroxine. That was the only treatment she'd been on.
So we are not sure if he's progressing as well.
Okay.
And for those who would have loved antifibrotics at the beginning, I think you're affecting more than 10% of the lung. So this would be a typical case you'd put in a study and start an antifibrotic and see if early does any benefit other than waiting to see if there's progression.
Why, if it is a CTD-ILD?
Well, this is the question we were trying to answer, that should we start both at the same time?
Oh.
And one of the criteria that people feel you are delaying is if the lung starts getting affected more. And here, I think you already have over 10% of the lung affected. Now to show progression. So we don't have that, we only have one.
Okay.
Yeah, so we can't show progression, so.
Okay, I think I have my answers. We'll treat whatever the rheumatologist says we treat. We won't biopsy. We will monitor closely for progression to decide when to start antifibrotic. Thank you very much. I'm very grateful.
Thank you so much, all of you, for staying on and for such wonderful presentations. I really enjoyed myself. I hope you did too. In fact, Prof. Buika, it may interest you, but we've put that topic, the issue of ILD screening for CTD. So there's actually a topic in our conference. I just want to read it. Screening in CTD-ILD. What, when, and for whom? And hopefully we shall get answers on that day in October. Thank you all. I want to wrap this up and let's give a clap to all ourselves, isn't it? I don't know whether the BI team has anything to tell us, but from our side, thank you.
Maybe I can say this, that number one is that after this we have dinner laid up for you in Maghreb restaurant. We shall just walk together. The second thing that I want to say is that I wanted us to take just a small group photo for those that are remaining. But allow me, as I conclude, to just say a big thank you to, first of all, to our speakers. They have come from the south, from the west, and from the east. And let's give them an applause, our speakers. I'm also grateful because, especially to Dr. Disiva and Dr. Forson, they have been on that online. You know, staying online is more difficult than being here physically. So let's applaud Dr. Forson and Dr. Audrey because of being there. We truly appreciate you, the Ghanaians, for being there and being persistent. We truly appreciate. But above all, we want to appreciate each one of you for the great contribution that you've given to this meeting tonight. I want to believe that it is not time wasted. We have walked here with some knowledge, maybe sometimes even difficult questions that we can go and interrogate further. But I believe this is for the good of the practice and more so for the benefit of our patient, because we shall be maybe looking at more parameters as we arrive to the diagnosis. So on behalf of BI is Bollinger in Gelhem, I want to say a very big thank you to all the participants that are here physically and those that have joined online, even those that have left because of the lengthy time. May the Lord bless you. Thank you so much. So allow me to wind up the meeting for those that are online. Thank you so much, Dr. Disiva, Audrey, or Dr. Forson, and the others that I can see from the other platform that probably is not showing up there. Thank you.
Thank you too. Thank you.
Thank you very
The
much.
recording has stopped.
Thank you and goodbye.
Bye-bye.
So maybe David can